Okay, this is the second part of first day of fifth World Congress Skull Base, fifth World Skull Base Annual Congress. And we will start second part by Professor William Caldwell. Please start sharing your screen.
Great. Sammy, can you hear me now? Can you hear me?
Yes, great.
You can hear me okay, is that right? Because I couldn't.
Yes, I can hear you well.
Okay, wonderful. Thank you. I'm sorry about the problems earlier. I'm in China and I've got a unstable connection here. So thank you, Sammy, Ada. It's great to see old friends. I enjoyed your talk, Aaron. I'd like to just talk a little bit about surgery in and around the orbit. And the reason I'm discussing this is that it's interesting because we've been interested in this for some time. And I want to acknowledge Taka Fukushima, who died last year, but he was my mentor and he was the one that really got me interested in working in the orbit. And he considered it part of the neurosurgical corridor. And I think it's interesting now. I was in Italy a week ago and we were teaching a course, and it was amazingly interesting. And there's a lot of interest now in orbital approaches. So even though the Egyptians did the early work, as you know, on excerebration for mummification, it was really the specialty being defined by the fathers of skull base surgery. And these are all in chronological order here. In the 80s and 90s, when the technology became available, and Don Simpson had told us the importance of tumor removal to the fullest extent. And this is where I'm from, a beautiful state. I don't have any disclosures that are relevant, but I will tell you that skull base surgery, I think, is very interesting because every tumor is unique. This is a patient with a terrible adenoid cystic carcinoma. And it's just a demonstration that we don't have any level 1 or level 2 evidence to treat any of this disease. And we're all learning as we go on. And I would say that skull base tumors are more difficult than most of the vascular cases for sure, especially some of these ones that are so routine and stereotypic. So where are we going? I think skull base surgeons must be familiar with the orbit, and I consider the orbit a sort of an orphaned area between ophthalmology and neurosurgery, because a lot of the neurosurgeons don't know it well, and the ophthalmologists are fairly timid when it comes to operating on the area and our tumors when they invade into the orbit. But if you consider this case, this is a woman who had a WHO grade 1 tumor removed from her middle fossa in 2004. And you can see this sphenoorbital ridge is all thickened, and that's hyperostotic bone with a sphenoorbital meningioma. And she then subsequently recurred fairly quickly and had several treatments, including two small operations through the orbit by the ophthalmologist and radiation as well. And now the tumor's progressed. It's in the cavernous sinus. It's encasing the carotid. She's lost vision already to the prosthesis, and she's really in trouble. So we'll perform a extirpation operation. And it's important to remember that the blood supply to the orbit comes through mostly the ophthalmic arteries. So if you isolate the apex of the orbit, you'll be able to isolate that, and we'll remove the prosthesis and then divide the ophthalmic artery here. And it really takes away most of the blood supply to the tumor that's invading the orbit. And after we do that, we'll then go ahead and dissect the tumor off of the brain and also off of the temporal lobe and the middle cerebral artery. And here I'm doing my best to isolate only the feeding arteries to the tumor and leaving the en passage vessels intact. And then we'll go ahead and resect the cavernous sinus as well. And I won't show you that for time reasons. But obviously this case has had radiation several times, and we need to close the dura properly. And we'll use a fascial allograft for that, and then a free flap with our ENT colleagues as well. And so This is a long operation. It's a long day. And this is the result that we'd expect to see, which is a complete resection. And she lived for several years after this. She had trouble with a CSF leak that I had to repair through the nose after surgery and put an EVD, but ultimately she did fairly well. As I mentioned, this is an orphan region between ophthalmology and surgery, and Al Roten left us an amazing legacy of all the anatomy studies that he did. And there's 7 bones that make up the orbit, and the young people should know this and know the anatomy of the orbit, because when we start to enter the orbit, we think about approaches. We use several different approaches to this region. This is the palatine bone, the ethmoid, and the lacrimal, which is a small bone behind the nasal bones there. And if you look at the anatomy of the nerves and the arteries as they enter the orbit, it's interesting phenomena that most of the nerves come in lateral and they go medial. This is the 4th nerve going outside the annulus of Zinn, and the V1, the first division of the trigeminal, running on top of the levator and going medial. The only nerve that stays lateral is the 6th nerve, the abducens nerve, which obviously serves the lateral rectus. But even the veins go from lateral to medial, and the ophthalmic artery as well. And it can go either above or below the optic nerve. The 3rd nerve splits into 2 nerves, the superior and the inferior division. The superior division supplies the levator and the superior rectus, and the inferior division subserves all the other nerves. So if you retract on the upper muscle complex, you've got to really be careful of the upper division, because you'll leave the patient with ptosis. 4 crosses 3 at the superior orbital fissure. This is a very important anatomical relation that I use to identify when I'm at the superior orbital fissure. It marks the superior orbital fissure, and when you have meningiomas involving this area, it's a good landmark. These beautiful images with all the fat gone. This is an amazing gift, and these are all included on the AANS website and also in Dr. Roten's lectures. And the anatomy is not complicated, but it's unknown to most neurosurgeons. And we now make it a point to teach this anatomy in our skull base courses. So there's 2 ways to think about the orbital approaches. One is a destination for taking our disease out of the orbit, or it could be a conduit to an intracranial approach. And I'll talk about both briefly. I like to generalize, and in general, the lateral and superior approaches, depending on where the optic nerve runs. So you don't want to traverse the optic nerve to the lesion. You want to come in from the side of the lesion and not interfere with the optic nerve, is usually a transcranial approach, either lateral orbitotomy or a frontotemporal or a superior orbital approach. And then these inferior aspect lesions and medial lesions are beautifully approached by endoscopic approaches, either through the nose or through the maxillary sinus. And I want to remind everybody that only the neurosurgeon has the capability to perform all the approaches to the orbit. So this case, for instance, this is an AVM in the orbit, confined in the orbit. And what we'll do is we'll perform a lateral orbitotomy to this approach. So you can see it's fed by the ophthalmic artery, and our endovascular surgeons were very reluctant to do anything with this because they were worried about interrupting the ophthalmic artery supply to the optic nerve. So we'll perform a lateral orbitotomy here and come in and directly identify the AVM in the periorbital fat. And then this is a relatively simple operation because it's a low-grade AVM with a single draining vein, and we're able to identify that and remove it. This is a sphenoorbital meningioma, and I'll talk about that later, but we use specific techniques to try and remove the tumor from the orbit in these cases. If you have a lesion, therefore, like in the medial aspect here, with some optic nerve compromise, visual loss, proptosis, we'll use an endoscopic approach to remove that. And this is a beautiful and simple approach, either transnasally or transmaxillary. But the whole idea is that you combine the maxillary sinus and the nasal approach into one. and then you remove the bone over the inferior and medial aspect of the posterior orbit, and then go after the tumor. And I won't show you that for the rest, for the respect for our time. This is a very interesting type of lesion that you may see very rarely. This is a case of a series of tumors that Sam Malmefti and I have collected over the years that we published. These are multifocal lesions of the trigeminal nerve. They're usually unilateral. It's a subset of schwannomatosis, and they have pearl-like lesions along the course of the trigeminal nerve, either first or second division usually. But I'll show you this. And what we'll do is we need to be familiar with the orbit, and and she's got disease in her cavernous sinus, cystic tumor in the orbit, causing proptosis as well. So we'll do a single approach to approach the cavernous sinus, V2 and V1 of this tumor. So orbitotomy with the craniotomy. So we've exposed the orbit as well with our craniotomy. And we'll now expose the first division. And you want to be really careful with this because you don't want to injure the first division because you'll leave the patient with an anesthetic globe and a blind eye over time. And then we'll extend this back and do a cavernous sinus approach. And here I'm doing a Dolink and a Kuba lifting of the cavernous sinus wall, and we'll identify the tumor in the cavernous sinus. And what you want to do is you want to expose the first division in this case, and we'll remove the tumor in the cavernous sinus. It's partially cystic here, and then extend our dissection out along V1 all the way along the upper part of the orbit. And it's fascinating that you've got a normal nerve in between these pearl-like lesions along the nerve. And you'll see what we do is we take care to try and just remove the tumor without removing the parent nerve and injuring the parent nerve. And I'm just sort of dissecting the tumor off the first division there and removing it very carefully. So ultimately, we finish, we'll close the periorbita, or replace the bone, and then you're left with this. And I've been following her for 8 or 9 years now, and she's got normal vision, and her nerve is working fine. So if you're careful, you can preserve the function. I have a whole series of these cases, these dramatic fibrous dysplasia cases. This is a young man from Nevada who I've operated on probably a half a dozen times. And you can see he's got so much thickness of the bone that he had headaches and had intracranial pressure problems. The optic nerve is often involved, and you need to decompress this. Very vascular tumor in this particular case. So they can be extreme. This is one of the worst cases that I've personally ever seen. What about the other approaches? So it's interesting because when you think about a lateral orbitotomy approach, the way we came to this is that it's really a full extension of the terional approach. So if you think about the limits of the terional approach, it's the muscle in your way, and you can get around that by stripping the muscle and reflecting it inferiorly off the scalp flap. But it was Yasirgil that really popularized the approach. And I had a Turkish fellow at the time, and we were talking to Yasirgil about this, and he'd seen that historical paper that we wrote. And he said, we haven't evolved the frontotemporal approach. And he was right. We didn't evolve it for 30 years. I mean, we did the supraorbital approach with an eyelid incision. The problem with the supraorbital approach is it doesn't get you lateral enough if you need to go down to the middle fossa as well. And so that's the limitation. Otherwise, it's a nice little approach. But when we were doing these cancer operations, and we do a lot of enucleation operations at the cancer center. Here's a squamous cell carcinoma in the orbit involving the muscles. So we were going to enucleate the eye. And when we do this, it gives you a beautiful view, extradural view to the cavernous sinus. Here's the anterior loop of the carotid. And it occurred to us that maybe we could come a little more anteriorly with our frontotemporal approach and use this to our full advantage. And these patients wake up like they've had a facial operation, not a neurosurgical operation. The distance between the lateral orbital rim and the cavernous sinus is 4 centimeters. It's not the shortest distance to the cavernous sinus. This is the shortest distance to the cavernous sinus. It's 3.5 centimeters through the maxilla. And from the posterior wall of the maxilla, is very short to the cavernous sinus. And you can extend this approach, and I think it's underutilized in many cases. Now, I think that neurosurgeons have long used transnasal surgery, but now we really perform transfacial surgery as well. And here's a giant trigeminal schwannoma you can see. And what we'll do in this case is we'll do a hybrid approach with transcranial operation, releasing it, and then also having the endonasal approach endoscopic to perform. Here's the trigeminal nerve that you're looking at from below. And we're dissecting the tumor carefully off the trigeminal nerve, taking care not to injure the carotid in that location. And this is the post-op scan with fat in the bed. So the lateral approach to the cavernous sinus is a very interesting one, and I think it's been used by a lot of people now to also expose the middle fossa. We had originally published this to expose the cavernous sinus, but it gives you complete access to the middle fossa. And I want you to think about this because I think it's a really efficient approach to remove medial temporal lesions. So originally we did this on cadavers, and then we did it on several patients. And we published this initial experience about 12 or 13 years ago now. But the advantage is that you don't touch the temporalis. There's no temporalis wasting. There's no brain retraction, and it's entirely extradural. So you can come down the lateral wall of the cavernous sinus, or the lateral wall of the cavernous sinus, and peel it off. And so here's a woman with ophthalmoplegia. She's got a lesion in her cavernous sinus. And what we'll do is we'll do a lateral canthal incision and extend it up into the eyelid. The eyelid incision is wonderful because it gives you a lot of freedom for retraction and exposure in this area. And then you can dissect out the lateral rim, and you can come as much frontally as you want with this. So we originally published this as a lateral approach, but you can come in superior lateral with the same approach as well, and combine this with the superior orbitotomy as well. So once you do that, it's a very simple matter then to just come down the lateral wall of the orbit, and we'll fit these plates before we remove the orbital rim. And then once we do that, you just drill out, staying outside of the periorbita. You can remove the lateral wall, but come right down on the temporal dura and then peel the lateral wall off. It literally takes about 20 minutes to do this operation. It's very quick. Here's the peeling operation, just like we would do through a frontotemporal approach. And this was a Epstein-Barr virus associated tumor from a previous bone transplant she had. But basically, when there's no closure, this was entire extradural in this case, and we just close the soft tissue and then close the cutaneous layer, and then remove the eye protector. Now, this has been extended now for a lot of things, and we've done this on cavernous sinus meningiomas. You can see you can remove the clinoid this way very easily, and we've extended the operation to now to take care of the entire middle fossa if you wish as well, and a number of other people have done that. It helps when you use the endoscope in deep. But I just want to show you this trajectory picture because depending on the angle you want to come in, you may or may not need to remove all the lateral wall, and you can come straight down into the middle fossa, cavernous sinus, Meckel's cave, anterior petrosal, and also the medial temporal lobe. And so here's an example of a case with a large cavernous malformation. And we removed the cavernous malformation for seizures in this case, and we left the lateral wall intact. So I won't show you the video for time, but we've also done amygdalohippocampectomies this way. It's a beautiful trajectory to the medial temporal lobe. And once you get into the ventricle, you can see the anatomy beautifully. and take the hippocampus back as far as you wish. So in my first 50 cases, and we're just getting ready to publish this now, you can see the lesions that we've gone after. We've initially decompressed the optic nerve, etc., but we use it now for temporal lobe lesions, and we've done tumors as well as infections. Now, a lot of people around the world have expanded this and used this corridor as a mechanism to expose the frontal as well as the temporal lobe. And you can see these windows that you can make through the orbit to allow that. And the endoscope really helps with this. This was a very clever addition in my mind. This was an issue of focus that we did, and Aaron published this. But Walter Jean uses AR, augmented reality, to overlay the tumor on the operative field and then decide how much bone he has to remove to be able to achieve removal of that particular meningioma. So these are the kind of advances that are going on. I think it's terrific. The last couple of minutes, I want to talk about sphenoorbital meningioma, and I'm going to switch gears completely because this, I think, in my mind, is an operation that requires a lot of exposure. And here's the problem. I showed you a case like this at the beginning, where the middle fossa tumor has been removed, but the hyperostotic bone, which incorporates tumor, is still left. And this is a very dramatic case of a woman from Eastern Europe, and she's got terrible proptosis. She still has vision in her eye, but you can see the tumors involving the extracranial space, the intracranial space, and the orbit itself, and then all of this hyperostotic bone. So very dramatic case. And I changed my posture about 15 years ago because I was very unhappy with the improvement in the proptosis that I was getting. And I'm going to show you what I've learned. We've got a series of 95 patients that's just being published in the Journal of Neurosurgery right now. And it's an experience where I've evolved my technique over the years to remove more and more bone. And so we'll look at the CAT scan and we'll decide where the bone is thickened and then remove the thickened and hyperostotic bone. And so usually it's involving the roof and the lateral wall of the orbit. And traditionally, these tumors don't involve the optic rim, the orbital rim. And so it's a normal landmark for use. So case in point, here's all this hyperostotic bone in this case, terrible proptosis. He had a tumor removed by a neurosurgeon previously, but never had improvement in his proptosis in his eye. He had exposure keratitis. And we'll go ahead, and this is what we'll achieve. We'll remove all that involved bone. So I want to just talk now, last couple of minutes, about how you deal with the tumor in the orbit itself. And this is the sort of focus of this large series that we're just publishing. So this is this woman from Eastern Europe, and you can see how bad her proptosis is. And so what we'll do is we'll do a large frontotemporal craniotomy in this case to remove all this thickened bone, all the extracranial tumor. And so we'll start off with the frontotemporal approach and drill out all the involved bone. And the bone is very vascular. It's like doing archaeology and trying to find normal anatomy underneath. The bone can be literally centimeters thick and very vascular in this case. And I don't embolize tumors, these meningiomas anymore, because we've had complications with embolization of the anterior fossa with some visual loss through collateral through the ethmoidal branches. So here's the orbit. The orbit's full still of tumor, and we'll remove the clinoid, which is thickened. And then I'm going to focus on showing you how I remove the tumor in the orbit. So we start just behind the orbital rim, and we'll find the limit of the tumor and find normal periorbita. And then we'll dissect down and find this interface between the tumor and the vascular supply that it's parasitizing from the orbit. Now, if you follow that dissection plane backwards, we use retractors for this. They're very helpful in this case. And then just take the dissection posteriorly all the way back to the annulus of Zinn. and then remove this. And you can see even with all that involvement of the orbit, the muscles are not involved in this case. So we'll close the dura, and I don't close the orbit. They have double vision for usually about 3 weeks and it resolves. And the reason I don't close the orbit is because if you do, they won't reduce enough. And also they can have early visual loss if you have any recurrence. So we've abandoned reconstructing the orbit with this approach in our facility. Now I want to show you what the scan looks like post-op, because here you can see how much proptosis she had beforehand. Look at the optic nerve now. So it's completely, the globe is completely regressed. And I'll show you what she looks like 2 weeks later when we put a custom cranioplasty in. And this is what her eye looks like. You can see here how bad it was originally, and now she's got normal ocular positioning. So the proptosis index in this series of patients, these are the first series that we published, shows that the eye corrects, but it does not overcorrect. So they don't get enophthalmos. It's a different disease than operating on a tumor in an intact orbit. When you have the meningioma all around the orbit like this, it tends not to overcorrect. So in this series, we've graded these tumors, and I want to talk about this because it defines the ability to remove the tumor. So we define 4 grades of tumor, and I'll show you the pictures that accompany the article. But grade 1 we call the hyperostotic tumor in the bone itself. There may be tumor in the intracranial space in the middle fossa, but there's no tumor involving the orbit. And they should all be removed well by drilling out the involved bone. Grade 2 is when the periorbita becomes involved and invaded. And again, we feel that these tumors should be removed completely because the periorbita can be removed and the muscles and the structures left intact. Grade 3 is when you have invasion of the orbit. And this complicates things because you'll have to decide if you're going to go ahead and try to remove the tumor, and then you're going to decide what to do with the muscles if the muscles are invaded. And then grade 4 is when you've got tumor involving the orbital apex around the optic nerve. And in these cases, it's hard to preserve function as well. And these cases, in my mind, are cases that we don't do aggressive resections unless we're going to do an exenteration. So we don't do partial removals trying to improve function on these patients. So here's 1, 2 is involving the periorbita, 3 is involving the muscles or the fat, and then 4 is involving the posterior orbit. So with that in mind, I just want to talk about resecting these higher grade ones and talk about the experience that we've had. So grade 1, we'll go ahead and remove it all. Grade 2, the same thing, and remove the periorbita. Grade 3, we'll remove it if we can, and then we'll decide whether we leave tumor in the muscle. And with younger patients, I'll remove the muscle that's invaded by tumor because the patients have double vision already, and you're not going to make them worse, and the ophthalmologist can straighten the eye out after surgery. And then grade 4, we're not aggressive unless we're doing an exenteration. So let me show you this grade 3 patient. And this reminds me of what Al Mefti taught me many years ago, is you have to explore and decide if you can remove this. And so I'm going to show you this case because it was very involved. And so what we'll do, left side, frontal temporal approach, I'm removing tumor down into the pterygopalatine fossa here. And what we'll do is we'll start off with normal anatomy at the apex of the orbit, and then remove the clinoid, open up the falciform ligament to make sure there's no tumor underneath the falciform ligament that could cause early visual loss with recurrence. And after that's done, then we'll take the tumor out of the orbit proper. And you can see the ophthalmic artery take off there. So you want to remove the bone all the way up to normal periorbita. I'm making some linear cuts here along the plane of the muscles. You won't hurt the function of the eye with that, but it offers decompression. And you can see now we're removing the periorbita, and we've removed, and the orbit now is like a muffin. It's expanded, and we're chasing the tumor down along V2 into the pterygopalatine fossa. So ultimately, this is what you're left with. He's had a good decompression, and we left everything intact. And you can see the muscles here are not involved. Okay. So we'll go ahead and close. You put fat around the orbit to avoid scarring, especially with the dural closure. And here's the patient postoperatively. And I want you to look at the scan because you can see the eye is reduced and the orbit's expanded, and his function improved, his visual loss improved, as well as a third nerve palsy. So you can do more than you think. And this just emphasized the technique, and this is all in the paper that's being published. But if you open up, expose the tumor invading the orbit, and I'm debulking the tumor now, and then we'll start this dissection plane anteriorly here. And once you find normal fat, you'll find your plane and just follow that along and peel the tumor back out of the orbit. And so here I'm finding where these vessels are supplying the tumor from the orbit. And if you stay in that plane, you won't hurt anything, and you can follow it back. And if it's invading the muscle, you'll identify it during this dissection. And then you can make an independent decision of whether you want to remove the tumor and the tumor invading the muscle as well. And you can see we're dissecting carefully, and then by the end here, she's had all the tumor removed from her orbit, and it allows her to have complete reduction of her prophysis. So with that, that's the last message I wanted to say. I think this data is in the paper, but basically it shows that the cranial nerve palsies are higher in the obviously higher grade tumors, and the visual loss is higher in the grade 4s. We didn't experience any visual loss in most of the other patients, and we had no mortality in this series using that aggressive approach. So we published the visual outcome with these patients, but this most recent publication is really dealing with the classification and the resectability of these tumors. So in conclusion, I think orbital surgery should be familiar to skull-based surgeons. It's part of our armamentarium. I think we're the ones that are equipped to take the tumor out of the orbit using our microsurgical technique. Only the neurosurgeons can perform all the approaches used to approach pathology in the orbit. It's generally forgiving structure, and I think most neurosurgeons don't appreciate that. It's a very common area for tumor recurrence with meningioma, given it's not removed completely. And finally, I think we need to be appropriately aggressive with the disease. If we can remove it surgically, we should, and avoid radiation, because when the radiation fails, these patients fail badly, and the tumors are often aggressive, and we've published series of patients like that before. And the risks of radiation are amortized over time. So I really like to avoid personally radiating young patients with benign disease, just for that reason. We need to better calculate the morbidity of radiation, which is spread over many years, as you know, in the lifelong management of disease. I've seen cranial nerve palsies 25 years after the radiation, and CSF leaks in a delayed fashion as well. So thank you very much. It's an honor to be here.
Thank you, Professor William, for excellent review and enlightening approach to middle fossa.
Sorry, I think you're muted, Adam.
Okay, thank you so much. Am I audible now? Okay.
I just want to make a comment. Hey, Bill, it's Jim Liu.
Hi, Jim.
I really enjoyed your talk. I fully agree that as skull-based surgeons, we have to be involved with the orbit, and that's been our experience too, working with neuro-ophthalmologists. I feel like they know the anatomy a lot better than us, but we kind of know the microsurgery and have a little bit more experience dissecting around nerves and vessels. I wanted to ask you about nuances in the intraconal meningiomas that invade from the sphenoid wing into the cone, and if they still have function left, and sort of at what point do you sort of decide, okay, function is still it's still a functional eye, and you're more conservative versus being more aggressive, trying to get the whole removal. And then the second question would be, have you encountered any CSF blepharoseals that don't resolve? And if so, what's
Yeah.
the mechanism and how to prevent or treat it?
Yeah, thanks, Jim. Both great questions. So my philosophy is that if they have binocular vision that's functional, I try to preserve that. And I'll do it as aggressive operation as I can without hurting them. And so we'll try to reduce the proptosis because the proptosis is uncomfortable for these patients. They can get exposure keratitis and go blind. I've seen that with the really bad ones. And so we really want to reduce the eye, protect the eye, and if possible, maintain vision. But if our ophthalmologist colleagues, and we've got some great neuro-ophthalmologists that I work with, feel that the vision's not worth saving, then we'll do a aggressive removal, and that may include the cavernous sinus if the patient has had radiation and failed radiation. So I don't do this extirpation or the exenteration operations of the cavernous sinus or the orbit unless they failed radiation personally. I don't like to radiate them. I like to be aggressive with surgery up front. So we go light up front and then we go heavy on the back end and we fight fire with fire if the patient has failed, and we'll do a salvage operation. Those are risky operations, but we have a fairly large experience, and I won't do it for malignant tumors, so malignant meningiomas, but I'll do it for recurrent benign meningioma. And then the blepharoseal question is an interesting one. We had one CSF leak in that series, Jim, and because you can't close the dura properly, as you know, through these approaches. You can put fat in there, and usually the periorbital fat expands and it forms like a fat graft on its own to help seal the leak. So what we do, if we're worried about that, is put a lumbar drain in the patient and use that for about 3 days post-op. And in the one that did have a leak post-op, we didn't use a lumbar drain, but we put a lumbar drain in and it resolved fine with a lumbar drain. So it's remarkably forgiving, and I think the reason for that is that once you open the periorbita, if you do a transorbital approach, the fat then expands and helps buttress the leak.
Thank you. Those are nice points.
You know what? It's interesting because when I talked about this stuff a decade ago, people weren't interested, but now there's a lot of interest in expanding these transorbital approaches because I think people are realizing it's a nice minimally invasive way to get into the middle fossa and take care of disease that extends into the orbit.
What are your thoughts on the transorbital endoscopic approaches that seem to be
Sure.
growing in popularity?
Yeah, so the approach they're using is exactly what we had described there, but what they're doing is they're using the endoscope primarily. So my feeling about it is that you don't need the endoscope if you're going to the orbit. So you can use the microscope or you can use an exoscope if you so wish. If you go past the orbit or past the region of the cavernous sinus, the endoscope is really helpful because it's a narrow, dark hole. And so when we remove medial temporal lesions, we'll introduce the endoscope after the bone work is done and the dura is open. So it's essentially the same operation. One difference that I have philosophically with a lot of the endoscopic people is the endoscopic people are going through the orbit for every case, but a lot of the medial temporal stuff you can do without going through the orbit. You just need to go along the orbit and thin the orbital wall out, and on that cavernous malformation case that I showed you. So you don't need to enter the orbit per se, but you can just use the orbit as your landmark to go down the orbital wall and reach the cavernous sinus in the medial temporal lobe.
Thank
Okay.
you, Professor Paul, for this excellent presentation and excellent discussion.
Thanks, Sam.
Thank you. Now we will move to next speaker, Professor Maurizio Iacoangeli. Please start sharing your screen.
Thank you. Can you hear me well?
Yes, yes.
Okay. Thank you, Sameh, and thank you to all esteemed colleagues for this great course, this initiative. It's really something that must be thanks to Sameh for this effort. I just try to share my talk, and you see correctly?
Yes, great.
Okay. I'm talking about the approach, the philosophy, I would say, to the approach to the posterior region of the third ventricle and the pineal region. As Professor Caldwell said, we are facing a different patient, different situation, different location. So we must have in mind some solution. And you see how many solutions sometimes we have for every case. So how can we survive in this jungle without falling in this curve that I partially tried when I was young, because at the beginning, after this course, watching many very skilled surgeons, everything looks like simple. But when you are in the operative room alone, that is not so simple. Needs year of study, skill and sensibility in the hand. So with time, we realize a sort of compromise. How can we shorten this learning curve? By mentoring. Mentoring as personal mentoring or like courses like this. You must hear from people that have a brilliant mind, a beautiful experience from you. I had the privilege to make a fellow with, at that time, Almefti and Perneschi, that was supposed to be the perfect opposite. One very minimal invasive supraorbital approach, the other big opening. But then, after years, I realized that there are only one rule, that you not touch the brain. So the famous word of Al-Mefti, take the bone, leave the brain alone, or Yasser that sometimes fight with Al-Mefti, oh no, I don't need to remove the bone. I just open the Sylvian fissure like a book, and then I reach every region in the brain. That is true. Because whenever it's possible, we have to try to follow without displacing, without traction on the brain. We have to try to follow the natural way. We have even to consider now that the societies change, the people change. Now the people prefer to live less, but live in good condition. Even a small complication, a small deficit can be not tolerated. So this is something that we have to consider in our decision making. I fully agree, because I have a very bad experience with the Professor Caldwell, that whenever is possible, it's better a repeated surgery than radiotherapy, because people suppose that radiotherapy, oh, is safe, it control the disease without operation. That is a false myth that we have to try to change. Of course, we have to consider that there is a technology. Technology is going to the minimally invasiveness. But in reality, the minimally invasive concept is a philosophy because thanks to the ancestors of SAME and even our master mentors, they already used some concept of the minimal invasive surgery. For example, the pituitary surgery, even not endoscopic but sublabial, or the retrosigmoid approach, all the operation, even for big tumor, were made through a very small hole. And this is quite funny. This is a mummies with the X-ray in which the philosophy of the minimal invasiveness was even from the Egyptians, where they, in the mummification process, because the external of the body must be without scar, but they have to remove all the internal organs for the mummification process. They invented this minimal invasive approach through the nose, under the axilla, or lateral, because the aim was the same: respect the body, but respect the eloquent organs, the eloquent area. However, during in my residency school, the residents always are more fascinated by endoscopy, minimal invasive, because they supposed that is the future and that's the best way to treat the patient. But do not forget that whenever is the case, we have to use even the so-called classical approach. This is a lady in which we made the mid-facial degloving approach. If you are in the operative room and see this picture, seems devastating. But then this is the lady 2 months after. You even hardly recognize the scar, and the patient is in a good condition without the tumor. So what is really the aim is to address the disease, exclude the aneurysm, remove the tumor, and so on. Coming back to the talk today, we have, of course, several operations. This is a tumor, the perineal tumor. In this case, this was an interactive lecture, but now I give you quickly the solution. This is, in my opinion, a very straightforward decision. Three main approaches to the perineal region. I favor the supracerebellar subtentorial approach promoted by Fedor Krauss, because you, according to the golden rules, that you follow some natural highway, that is the supracerebellar cistern, to reach the lesion quickly without any effort. This is a general rule, but in perineal region tumor, at least in my hands, the sitting position is the best, because the cerebellum fall down and that natural ways is even more open. And you see, this is a very educative video in which there is a tentorial meningioma, but you see how by cutting some cerebellar vein, the cerebellum fall down quickly, and without any spatula, without any retraction, you can work quite easily. So the selection of the best approach and the selection of the best position is essential in any treatment. And this is the video of the procedure, very straightforward. But this is another case in which I want to show you how, keeping in mind the minimal invasive philosophy, in this case, in order to give a further way of outflow of the CSF, in this case, after removing the tumor, in order to avoid the positioning of the shunt, we from posterior with the endoscope, we try to make a third ventriculostomy, but not on the floor of the third ventricle, but in the lamina terminalis. In this way, you have a double pathway of the flow of the CSF, because in case, and it happened to me, a collapse of the wall when you remove the tumor, then this is this additional way. And you see here how beautiful is the anatomy with the fornix, the anterior commissure, and just doing a small hole in the lamina terminalis, you see the flap, and you see from posterior to anterior the anterior circulation vessel. So this is some additional way in order to provide a minimally invasiveness. And you see here the air anterior to the lamina terminalis with the hydrocephalus controlled without any further shunt positioning. This is a similar case. It's possible to use the Krauss approach, but in this case, we see that in this case we use the supracerebellar infratemporal approach, but in this case the quadrigeminal plate was pushed down. So from this way, I have a very straightforward way. In this other case, the lamina terminalis was pushed upward, so in the way of the approach, with the lack of the possibility to remove potentially, theoretically, the inner part of the tumor without making some damage. Because in the selection of the approach, at least theoretically, unless we can find something that prevent the total removal for some unsupposed thing during the operation, but the approach should be selected in order to at least to expose all the tumor borders. And in this case, we selected another approach. With the Krauss approach, we are going from posterior to the anterior. Taking the experience of this case of a craniopharyngioma, during this case, in the final exploration of the tumor, we succeeded in reach the posterior pineal region, making some hole in order to avoid the positioning of the shunt. And you see the habenular commissure, the posterior commissure, and the possibility, this is the CSF comes out, and with the possibility to, from anterior, to reach the posterior part. So, backing back to that case in which the quadrigeminal plate was displaced upward, in this case, we selected an anterior approach, but that is theoretically, but it was so during the operation, completely cisternal. So with the theoretical possibility to not touch the brain. You see, this is the pointer of the navigation system, and you see sliding in the subfrontal approach, translamina terminalis, through the third ventricle, we are able to reach the lesion just passing through the cistern without violating, at least theoretically, any eloquent space. Of course, the corridor is narrow, but narrow is even the nose, even the retrosigmoid approach. So with the help of the endoscope and the some skill in the hand, you see this is we reach the posterior region of the third ventricle, and we were able to completely remove the tumor. So this is how thinking globally is possible to address the similar lesion, but different. In order to enhance the minimal invasiveness is even applicable to the open surgery. I was, it is nothing because this patient at least was in good condition. But this patient with the disc colloid cyst and the transcortical approach, you see how damage in the brain. Of course, someone said that we have a redundant brain, so you don't need it. And this patient stay well, but still there is a damage. So in this other patient, we selected the transcallosal approach because transcallosal is even a cisternal way. So we slide on the forks. And you see in this postoperative MRI is hardly recognizable the approach. So the concept of minimally invasiveness could be always considered. And you see here, this was a combined approach, microsurgery, microsurgical and endoscopic. So we try to move forward to this. And in this other case, in which you only recognize the approach in the very medial slice section of the MRI, we try to move further and try to perform a sort of pure endoscopic transcallosal approach for the posterior third ventricle lesion. In this case, I don't know why. Okay. With the use of the piezo, we perform a craniotomy. Then, with the navigated endoscope, we just slide along the forks and with the same endoscope, pushing a little bit down, make the callosotomy. So even minimize the callosotomy because the callosotomy was made just the length of the, as you see, the length of the endoscope. And then at the end, you see the small hole and the artery is dislocated laterally. And then the procedure is, as usual, it is the endoscopic procedure as everything, as every operation. And this is the another video in which, sorry, in which we can realize how the path is narrow but possible and through a very limited approach. So this can reduce, always reduce, and the tendency will be toward zero approach related complication, at least whenever it is possible. Sometimes, fortunately, the lesion suggests us the approach. This is a big brainstem cavernoma. In this case, I think there is no question that the approach is posterior, telovelar, but really there is an highway created by the tumor. So, in conclusion, in the selection of the approach, there is probably only one rule. One is do not touch the brain. If you do not touch the brain or minimally touch the brain, there will be not consequence. I use open endoscopic, all the kind of the approach. Now I see that the young generation are fascinated by the endoscopy, the robotic navigation. That is true. It is fundamental. But still, we have not to forget the classic approach that in some case must be used. And furthermore, there is not a competition between macrosurgery exoscope, endoscope, both contribute to the minimal invasive philosophy. And anatomy is fundamental. If you know Pernesky say, if you know the anatomy, at least you do not make damage. You cannot remove the tumor, but at least you cannot damage. And if you know the potentialities of the instrument, of the approaches, you can even think something that is uh, rising the bar of our approach. And then this is something funny for me because if we watch back at the history, now we say, oh, maximal safe resection, but the meaning of maximal safe resection is the Hippocrates sentence, primum non nocere. So, of course, we have to resect the tumor according not to go damage. And to conclude, this sentence for me is very, I don't know how to define of the great, one of the great that I have read 1 century ago by Cocker, that is exactly the inner meaning of the minimal invasive philosophy. Approach should be as large as necessary and as small as possible. Few words, but that reassume all the philosophy of the minimally invasiveness. Thank you for your attention.
Thank you, Professor Moisio. It was an amazing talk and a lot of learning for all the
Thank
viewers.
you.
So, forum is open for questions. Comments.
It's good because this means that everything was clear or that everything was not clear or not discutable. So that's good.
Professor, here,
Ah,
can you hear me?
hi. Well, hi. Very well.
Professor Mauricio, very nice presentation. Very nice presentation. I think the new era perhaps could be the use of exoscopes. I prove the new exoscopes are very good, and with the microscope, especially with the biggest, you have some problem with the position. Perhaps exoscope could be a solution in the future about this. But very nice presentation. Congratulations.
No, of course, exoscope, microscope, but do not forget that with the endoscope you have a better anatomical position, maybe a better working angle. But the result is that you do not harm the brain. So the philosophy is the same. If you use the endoscope, if you use the microscope, the exoscope, it's not doesn't matter. The robot, the navigation. We cannot with the navigation. We have a good tools, but we have to learn the anatomy. I cannot trust totally to the navigation. So the navigation, especially when the anatomy is confused, especially in recurrent tumors where the anatomy is not so clear, is a very great help. But you must have in mind what previous speaker says, oh, pay attention here, this is the starting of the nerve, all the nerve crosses from lateral to medial. So you have to imagine how the expecting anatomy that you will have. Then, of course, all the tools are welcome.
Okay.
Okay.
Thank you so much. Thank you so much.
Thank you. Thank you, Samet. Thank you, everyone.
We move to our next presentation by Professor Roberto Herrera from Argentina, Buenos Aires. He's no, he is known by everyone in the neurosurgical circle, no matter where he's practicing. So Professor Herrera has contributed a lot in teaching and training, and a truly leader for all the neurosurgical fraternity. Professor Herrera's today's topic is insular region gliomas, the role of low field intraoperative MRI. So over to you, Professor.
Okay. Thank you very much. Thank you again, Professor Sami, for this amazing meeting. I'm going to share the screen. Okay. I'm going to talk about our experience with excuse me, because I'm traveling from Buenos Aires to my city. I'm in my car, but no problem. Can you hear me? Good?
Yes.
Okay.
Your voice is clear.
Okay, I'm going to talk about our experience in glioma region tumors. This is our clinic in Buenos Aires. And checar esto. Ahí está. Okay. I think this is not the real treatment result in glioma surgery. I think these results are based on incomplete surgical resection, and the guidelines recommend to do maximal safe resection feasible in gliomas, both of them in high-grade gliomas and in low-grade gliomas. But in some series of glioma surgery, the number of gross total resection is only 6, 10, 12% of the total when we are operating and removing a glioma. And the most of these patients with incomplete low-grade glioma removals die within the first 3, 4, 5, 7 years from recurrence or malignant transformation of the tumor. And it is a bad result of the surgery. With subtotal resection, more than 50% of the patient will be dead in a few years. And it is very important difference between gross total resection and subtotal resection. In insular gliomas, watch and wait is not an option. You can see how the glioma will grow in 1, 2 years. This, you can see this case from September 2005 and September 2007 in 2 years. It is a huge tumor. You can operate, yes, but the surgery will be not the same. We can decide operate at this time. You can remove, but you can have a patient with this hemiparesia, with some neurological dysfunction. Biopsy plus radiotherapy in low-grade glioma is not an option. It's not an option. You can see this small tumor in region area, October 2009, and 1 year later, this patient died. This is bad result. It is the worst result in low-grade glioma. You have a lot of tools to operate glioma. We can use anatomy with craniometric points, awake surgery, neuronavigation, biopsy, intraoperative biopsy with pathology, endoscopy, neurophysiology, brain mapping. I'm going to talk about our experience with this, with intraoperative MRI in very close, very near to 1,000 of gliomas operated. Of course, it is very important to know the anatomy of the insular region. That is it is a complex anatomical area, but it is necessary to know the anatomy, of course, first of all. And the same with the vascularization of the insular area. It is very important to know this. But blind surgery nowadays, in the era of the computation, of the robotics, of the artificial intelligence, blind surgery is unacceptable in modern neurosurgery to operate a glioma, because it is very difficult to distinguish the tumor from the normal brain. Where is the tumor? How much tumor I remove? How much tumor I have to remove? We can detect the tumor even using microscope. Everybody know this classification, but this is an anatomical, it is a physiological classification, but to decide the approach in insular tumor, I prefer Shasaki classification. I think it is a more anatomical and surgical classification. Insular pure with frontal operculum, with temporal operculum, and the pan-insular tumor with both operculum. You have this, you can see here this tumor. In 2005, it didn't enhance with contrast, but 2 years later, suffer malignant transformation, and this is the images. We operated at that time, I think we operated this ligament in 2005. We operated awake in that years. Nowadays, in only a few cases, very selected cases, we operate awake. And using intraoperative MRI. Here you can see this area of the tumor here, this area. And this is after removing the tumor, a good resection. This is the brainstem 28 months after surgery. The tumor has no neurological function. We never found function inside the tumor. It is the same in functional MRI. The eloquence areas are around the tumor, never into the tumor. And we check the same when we do electrocortical stimulation. I'm going to show how we operate using intraoperative MRI. This is our new device in the new operating room. This is the view from the technical area that is part of the operating room too. And this is the device. This is the magnet. We operate in safe area here, and when we need to do a control, when we need to check, we move with a simple rotational movement, the stretcher, the surgical bed, and put the patient in position of to do an MRI. This is the compatible headrest, and this is the area of surgery. And we remove, when I want to do control, we move the patient, and in less than 4 minutes, we can have one complete sequence, T1, T2, flare sequences. I'm going to show you some cases using this device and our previous device, which was a Philips system, open to. This is a 0.25 Tesla intraoperative MRI. It is a simple device, practical, easy to use, fast, neurosurgeon friendly, and respect the condition of the surgery. You can operate aside of the magnet. Here we are doing the craniotomy, and with this simple movement, you cover the patient with a sterile surgical field, move the patient to the magnet, and put this coil, and you can see here in less than 4 minutes, you can have one complete sequence with contrast or without contrast, and you can reevaluate with your team the new images and decide if I have some tumor to remove, or if I need remove anterior area or more posterior. You decide. You have this possibility to do reevaluate the step of the surgery, and you can repeat this as much time as you need, and go on, continue with the surgery, go on with the surgery. This is a case with this frontoinsular tumor. This is preoperative functional MRI. This is the area of the tumor. This is the preoperative MRI with this tumor here. It was a low-grade glioma, and this is the first intraoperative control. We can see clearly this tumor here, this area here. We can see the tumor in coronal view and in axial view here. We go on, continue with the surgery, and in the second control, intraoperative, we can see this remnant tumor of here, the same here, the same here, and you can repeat this step by step during all the surgery. And this is the final control with a very good resection of all the tumor. The head is still open, and this is MRI 3 months after surgery with in T1 and in T2 with complete removal of this tumor. This is the patient a few months, a few days after surgery, and this is the surgical field after removing the insular tumor completely. In high-grade glioma, the procedure is the same. Here you can see this tumor, insular with expansion to frontal lobe tumor. Here you can see this tumor here. And this is the same. This is the first control with this tumor, important tumor remnant here and here. Second control with this tumor remnant. And this is the last with complete removal of the tumor. We are satisfied with the resection that we achieved. And this is the patient 26 months after surgery. The evolution, the outcome is very different if you remove completely. In both of the cases, in low-grade glioma, we can achieve decades of survival, and in high-grade glioma, we can extend the survival in many cases to 3 years. This is a low-grade glioma, typical insular glioma. It is, in this case, we don't have operculum infiltrated by the tumor. We have to do Sibian fissure open. We need to open Sibian fissure. This, and here we expose the tumor. This is the tumor. This is temporal operculum, frontal area, and this is the insula. We can see the vessel, the middle cerebral artery, and their branches. And we remove using cavitador ultrasonic cavitator. You can use bipolar coagulation, the micro dissection, and this is the sequence. This is the tumor. We remove here. We expose the vessel, protecting them, and this is the final aspect. After removing completely the insula, this is the last control, and you can see here the vessel completely normal and preserved using the ultrasonic aspirator. And here we did a we did a fusion between intraoperative MRI and surgical field, and this is the resection is exactly respecting the deep structures of the brain, but with this grade of removal. This is previous to remove the tumor, and this is the last view of the surgical field. And this is the patient a few days and several months, and this is her MRI with very good and excellent removal of the tumor. The image is intraoperative. Is very important to achieve this maximal and safe resection in this tumor that we can't distinguish from the normal brain. This is another case. This is the preoperative, this is intraoperative, and this is postoperative. Here you can see how we remove temporal lobe, insular lobe here. This is the patient completely normal. This huge tumor, this peninsular tumor with the extension, frontal lobe, temporal lobe, and with this extension here to the midline. And this is the postoperative. We did, in this case, we did 5 intraoperative MRI to achieve this result. And this is the patient 5 years postoperative. This tumor, this insular tumor here, T2 flare, T2, T1, the incision is big incision to expose completely the insula and both operculus. This is the first intraoperative MRI with this remnant of tumor here, this tumor remnant here, this tumor remnant. You can see with very good detail the remnant of the tumor. And this is the last intraoperative MRI with no tumor, no more tumor. And this is the high field MRI 3 months after removal of the tumor with complete resection, preserving the rest of the brain. In children, it's very important to have this intraoperative control. For example, in this very difficult glioma to operate, this is the first intraoperative MRI with this tumor remnant here. We can detect this important area of tumor. And this is the last intraoperative MRI with complete removal of the tumor. This is the baby, 3 years old. And this is the baby a few days after surgery, 2-3 days after surgery. This is the patient 4 years postoperative, no tumor. And this is the patient nowadays, 15 years postoperative. This is his last intraoperative MRI. I think the results, I insist in this because it is not the same to remove partially a glioma, low-grade glioma, and have a patient with 3 years survival. If you can have decades of survival, removing completely these tumors. For conclusion, I recommend our strategy is the following. For a pure insular tumor, open sylvian fissure and go through the sylvian fissure. In this case, if you have frontal operculum compromised by the tumor, infiltrated by tumor, or operculum, temporal operculum, you have to begin by resecting the operculum which is affected. If both of them are infiltrated by tumor in this pan-insular tumor, is important to remove in the first time the operculums, because you can have better access to the insular lobe without a fight with the Serbian fissure. And it is easier to after removing the operculums. Professor Jasarkil in 1994 said about in the future operating rooms, the 3D images. Osama Al-Mehdi professor said in 2001, I see an intraoperative MRI in every neurosurgery operating room of the future. Professor Sami said, nobody wants to be operated for a glioma without having the control during their surgery. We don't need to discuss about it if it is necessary or not necessary. If you have intraoperative, you have advantages. I insist with this because I think we are in the next times but now and at this present we have to consider the images into the operating room. We can't operate blind glioma. Orthopedic surgeons are operating using X-ray. General surgeon operate using ultrasound. We can't operate brain glioma only depending of the surgeon experience or the anatomy. We need the images intraoperative. I think it is all. Thank you for this opportunity.
Thank you, Professor Herrera. Was excellent and honored. We are honored to attend this. Now, any comment, questions? Or...
May I ask a question?
Sure, Professor Mario.
For practical reason, we try to have because the intraoperative IMRIs or some other from Braille Lab is too expensive and maybe not too useful. We try to have an intraoperative CT scan, but this low field MRI is how say so heavy, is adaptable, because our problem was the floor of the operative room that is wasn't enough strong to support, so we have to reface everything. Do you use this low field intraoperative MRI free, is movable, or you need some special architecture, a special room?
Okay. Yes, intraoperative MRI for control of the surgery. Hello?
Yes, I hear you.
Are you hear me?
Yes, clearly.
Okay. Can you hear me?
Yes.
Okay.
Yeah.
I can see you. I don't know what happened, but no problem. The intraoperative MRI was a brilliant idea from the beginning. Nothing can discuss the advantages, as Professor Sami said. But the problem were the devices. It is so crazy to move a magnet with 15 tunnels hanging from the ceiling from one room to other room. It was crazy. I think the problem were the devices. But the different companies in India, in United States, in Italy are working with these small devices because the images of these devices are much better than 20 years ago. And with the artificial intelligence incorporated and new neuronavigation incorporated too in these devices and the fusion programs, the image is enough to remove the tumor. You can see my results. And these devices, this that I am using in the last 3 years is an Italian device. And you can put this in a normal operating room, 6 for 5 meters. You don't need enhance the reinforce the floor. You don't need nothing, and you can use 1 meter far away from the magnet. You can use microscope, endoscopio, exoscopio. You can use normal instruments, computers, everything. Only 1 meter out of the
Yes, yeah.
center of the magnet.
No,
Don't modify the surgery.
I completely agree of the necessity because it's impossible even with the awake surgery, the best monitoring, just to remove even the last centimeter of tumor. But if you see the tumor intraoperatively, I agree that is a great help. The problem was the device, as you said, the device. But if you say that this is very simple, adaptable, movable, and just 1 meter away from the magnets, you can use the normal, not a magnetic instrument. That's great. Okay.
Yes, yeah, I think this is the future. Professor Michael Berger, you can see one conference
San
of the
Francisco.
professor. Yes, in the last 1 year ago, he said that he's working with a new device similar to this, and he said that the future in glioma surgery is the low field intraoperative MRI.
Thank you. Thank you,
Professor Herrera,
Roberto.
Professor Herrera, do we need MRI compatible instruments with this low field? Because the cost
No,
is
you can operate with in normal way. You don't need nothing, only the magnet. And you can use normal microscope, normal bipolar. You don't need nothing because when you rotate the patient and put the patient into the magnet, the instruments are out of the magnet. You left the instruments in the table of the nurses. But to operate, you use normal devices, normal computers, normal photography cams. Don't need nothing. You operate normal. You need this small magnet and into the operating room. And in 4 minutes, you have complete sequences. I disappoint with away surgery because 80% of the patient can be operated awake. We can't operate awake children, for example, babies, very elderly patients, prone position patients, midline tumors, pineal tumors. You can't operate and operating awake in more than 60% of the cases, there were tumor remnants. It's not solution because the difference in the survival is between complete or partial removal.
Thank you, Professor Hoya, for this very nice presentation and for very nice discussion. My last question is about, can you make tractography with this low field MRI?
No, no. But it is a very important question. You can fusion. You can fusion with the preoperative, and this device has a very good fusion program because the repairs, the references are the sulcus and gyrus, not the bone, and you can compensate the shift, the brain shift. But I say always say the same. To operate an aneurysm, you have to do angiography previously to the surgery. When I'm going to operating room, I know how is the aneurysm, where is the neck, what kind of clip I could be need. In the tumor is the same. I did in all of the cases a spectroscopy, tractography, functional MRI, but previous to the surgery. And then intraoperative, I fusion this image if I need it. I fusion with my real-time images.
Thank you once again for this very
Thank you.
nice discussion. Thank you. And now we will shift to next speaker, Professor Mahdi Darmoul. Please start sharing your screen.
Thank you,
Thank
Sami. I can follow connected because I'm traveling. I'm in the road.
Thank you.
Bye-bye. Thank you, everybody.
Bye-bye.
Thank you, Professor.
Good evening, everybody. Good evening. You hear me?
Yes,
Yes.
please share your screen.
First of all, I would like to thank the organizing committee and especially the president of this Congress for their kind invitation and for this opportunity. I will share my screen now. Full screen. You see my screen?
Yes. Please go ahead.
Okay, I will talk about neurosurgical management of Cushing disease and especially about my personal experience. Cushing disease is a spectrum of clinical manifestation due to ACTH secretion due to adenoma and essentially microadenoma in 80 to 90% of cases. The diagnosis and management of Cushing are usually challenging, and the recommended screening test for hypercortisolism include the low-dose dexamethasone suppression test, urinary free cortisol in 24-hour output collection, and midnight salivary cortisol measurement. The tests for subtyping include the high-dose dexamethasone suppression test, the CRH test, and in some cases, the inferior petrosal sampling. Patients with Cushing disease have increased rate of mortality and morbidity with median survival of 5 years, and the first line treatment is transfemoidal surgery. We should do the maximum of with the aim of complete removal with preservation of normal pituitary gland function. And we have a rate of remission of ranging from 70 to 90% of cases. Cushing disease is rare and complex, should be managed in a high volume center with a multidisciplinary team. Surgical failure is a relatively common problem, either due to persistent hypercortisolism after first transfemoidal surgery or due to recurrence after initial remission. Long-term follow-up is mandatory, and several therapeutic options we have for recurrent Cushing disease. We can do first, second transfemoidal surgery, medical treatment, radiotherapy, and at the last, bilateral adrenalectomy. We present our theory. It is a retrospective study done in Monastir, in my department, Monastir Neurosurgery Department, over 7 years, between 2016 and 2022. And we have collected 32 patients operated for Cushing disease with a mean follow-up of 37 months, ranging from 6 months to 6 years. The median age is 27.8, ranging from 12 to 58 years, and the maximum of patients are in the between 20 and 29 years. We have more female than male, 23 female for 9 male. And the clinical presentation, we have faciotruncal obesity in all patients, 100%, gain of weight in half of patients, diabetes in half of patients, hypertension in half of patients, skin signs in 37.5%, and osteoporosis in 40.6% of cases. The endocrine disorder, especially, we have most patients have hypercorticism. And we have other endocrine disorder like true hyperprolactinemia, disconnection hyperprolactinemia, and thyroid failure. MRI feature showed microadenoma in more than half of patients, and microadenoma and macroadenoma in 13 patients, and no adenoma was seen in MRI in one patient, only in one patient. This is coronal MRI showing microadenoma in the left side. Among the KNOSP classification, most of patients are classified KNOSP 0 and 4 KNOSP 1 and 3 KNOSP 2. All patients underwent transfemoral surgery by microsurgical approach in 22 cases and endoscopic approach in 10 cases. And we did complete removal in 87.5% and subtotal in 12.5% of cases. This is the total removal, especially in patients with classified KNOPS 0, and subtotal resection in patients with KNOPS 2. The early outcome, we have amelioration of symptom and biology, and we did initial reoperation for 2 residual tumor and radiotherapy for 2 residual tumor in the cavernous sinus. The histologic examination confirmed the diagnosis of Cushing disease in all cases. And after the last follow-up, after a mean follow-up of 37 months, we have 20 cases of remission, 62.5%, recurrence in 12 cases, and these 12 cases were reoperated. And we have a second recurrence in one case who was treated initially by medical treatment, cortisol receptor antagonist, and he did not improve it, and he was reoperated for the third time. And here I will present 2 case illustrations. The case one is a 68-year-old man with past history of diabetes, hypertension, coronary, and complaining with asthenia. On examination, we see facial erythrosis, proximal muscle amyotrophy, and laboratory confirmed the diagnosis of Cushing disease. Here, the MRI, we see in the right side microadenoma in the coronal and sagittal MRI. We did transfemoral endoscopic approach, and this is a short video showing the resection of the microadenoma by endoscopic transfemoral approach. Here, after drilling the floor of the cell and after removing the floor of the cell, we coagulate the dura, and we will here cut the dura. We open the dura in the right side, the side of the adenoma. Here the location of the adenoma, and after opening the dura, we will remove the With the small curette, we will remove the adenoma. And here we continue with we have complete removal. Here, after the removal, we have good hemostasis. And we did total adenomectomy. On postoperative course, the blood cortisol was normal, no diabetes insipidus, no CSF leak, and blood pressure stabilized and blood sugar also stabilized. And actually, the follow-up is about 12 months. The second case is also a male, a 29-year-old male with diabetes, morbid obesity, apnea, sleep apnea, hepatic steatosis, mediastinal and pericardic lipomatosis, cardiomyopathy. On examination, obese with BMI 44, buffalo neck, faciotrancular obesity, skin stretch mark, facial erythrosis, and the laboratory showed blood cortisol high, urine cortisol high, and the diagnosis of Cushing disease is made. And the pituitary MRI showed macroadenoma about 12 millimeter of diameter here in the sagittal and coronal. You see this adenoma. And this patient underwent endoscopic endonasal approach with endoscopy, and we did complete removal. And the postoperative course was marked by transient diabetes insipidus, and blood cortisol was normal. And we have also stabilization of the blood sugar. And the control CT scan of the first day postoperative showed the complete removal of the adenoma. And actually, the follow-up is about 2 years, and the patient lose his weight. We review the literature concerning this, the management or actual management of Cushing disease. We select some recent article. Here, surgery in Cushing disease, first-line treatment and role of recurrence of after pituitary, management of Cushing disease, other article. Endoscopic endonasal transcavernous approach for invasive corticotroph pituitary adenoma. And the conclusion of the management, Cushing disease should be assessed by a referent endocrinologist. Surgery is currently the first-line treatment. If pituitary MRI show a well-limited adenoma, the surgical resection is performed by mononostril endoscopic endonasal approach. And we can have high reported rate. We have high reported rate of postoperative endocrine remission, ranging from 88 to 91% in the literature. If no adenoma seen on preoperative MRI, we should do surgical pituitary gland exploration as the first-line treatment, usually after inferior petrosal sinus or cavernous sinus sampling. And we can have a remission rate in the literature ranging from 31 to 80%, depending on surgical expertise, adenoma identification during surgery, and technique of hypophysectomy in case of negative exploration. We have some tricks in the surgery in Cushing disease. For the positioning, the patient should be placed in a semi-sitting position, slightly different from standard position used for pituitary adenoma, to avoid excessive bleeding from fragile mucosa and to obtain a better deflection of the head and reduce intracranial venous pressure because of the weight gain over the chest and abdomen. For the nasal and sphenoidal steps, we should limit excessive manipulation of the endoscope that could damage the fragile nasal and sphenoid mucosa. The nasal surgical corridor may be narrow. Centrifugal drilling under navigation is recommended in this case, and bleeding sphenoid bone hemostasis is obtained using wax application with cottonoid. For the sellar step, the sella turcica is not enlarged in Cushing disease and often covers the thin pituitary gland. The sella floor is opened using high-speed drilling in a centrifugal fashion. The dura is cut in an inverted U-shaped fashion, allowing an exploration of the interpituitary gland. In Cushing's patient, a large inferior cavernous sinus extending over the anterior basal dura is usually found. And in these cases, the dura is firstly incised horizontally above the sinus, then the sinus is coagulated by a bipolar, cautery, and sectioned down. This is the position in the case of Cushing disease. If the adenoma is visualized on preoperative MRI, the targeted adenoma is identified and resected. If no adenoma is visible on preoperative MRI, the third pituitary gland is incised horizontally. In case of lateralization on cavernous sinus sampling, the pituitary exploration always starts on the suspect side. The pituitary gland is explored using small curette. If an adenoma is identified, exploration is stopped and resection is performed. Well circumscribed adenoma are removed by selective adenomectomy, while poorly circumscribed adenoma are removed by enlarged adenomectomy, including a border of the junctional surrounding pituitary tissue. If no adenoma is found on one side, the other side is explored. If no adenoma is identified, a partial hypophysectomy, including the inferior third of the pituitary gland, is decided, including both the anterior and posterior part of the pituitary gland. There are specific perioperative considerations. Preoperative MRI is essential to identify a lower anterior insertion of the diaphragm. In such cases, we advocate that sella dura be incised at its basal part to avoid immediate CSF leakage. If no adenoma is visualized on the first MRI, a second dedicated pituitary MRI should be performed at an expert center to identify a potential surgical target. Most of patients can go back to the regular neurosurgical unit 3 hours after surgery. On average, the patient is routinely discharged 2 days after surgery. In patients with additional partial resection of the neurohypophysis, the rate of diabetes insipidus may be higher. Special attention should be paid to postoperative follow-up with the possibility of introducing desmopressin therapy. Postoperative remission, early predictor of remission include general indicator of hypoadrenalism, including low fasting serum cortisol 2 micrograms per deciliter, low 24-hour urine-free cortisol level below 20 micrograms per 24 hour, low serum ACTH less than 5 picogram per milliliter, or low midnight salivary cortisol within the first week after surgery. Remission is seen in approximately 80% of patients with microadenoma and 60% with macroadenoma, with overall remission rate of 68 to 91%. Patient in remission required glucocorticoid replacement until a cortisol stimulation test demonstrated hypothalamic pituitary adrenal axis recovery. This is an algorithm for the Cushing disease. We have MRI. If the MRI showed visible adenoma, we should do adenomectomy. If no visible adenoma, we should do cavernous sinus sampling. And if no result, we should explore both sides. If we have adenoma identification, adenomectomy. If no adenoma, partial hypophysectomy. If the cavernous sinus sampling is positive and without lateralization, same thing. With lateralization, we explore the suspect side. If adenoma is identified, adenomectomy. If no adenoma, we should do partial hypophysectomy. And here, reoperation for persistent disease for patients who do not meet criteria for immediate or delayed remission following initial surgery. Early reoperation for persistent disease is often recommended. Remission rate in reoperation for persistent Cushing disease range from 40 to 70% of cases. Although early reoperation is technically less difficult, data support waiting until cortisol level have decreased before proceeding with a second surgery, as delayed remission may occur as late as 1 month after surgery, and patients with mild hypercortisolism or cyclic Cushing disease may not have marked postoperative hypocortisolism. Reoperation leads to higher rate of hypopituitarism, diabetes insipid, and CSF leak. Reoperation For recurrent disease at 5 years occurs at a rate of approximately 10 to 15%, increasing to 20 to 25% at 10 years, or approximately 2% per year. Regular follow-up is mandatory. Late night salivary cortisol level and 24-hour urine-free cortisol level are commonly assessed. MRI 3 Tesla with optimized protocol, post-contrast flare sequence, post-contrast 3D sequence, combination of MRI 3 Tesla and methionine. PET can do the diagnosis in 100% of cases. And the treatment option for recurrent disease: to repeat the first line treat, to repeat the transfemoidal surgery in a high volume center, considering tumor feature such as size, invasiveness, and extracellular extension. Remission rate after reoperation vary widely in the literature, ranging from 40 to 80%. Second treatment, radiation therapy. Third, we can also use medical treatment with a new pharmacologic agent. And at the last thing, we can do bilateral adrenalectomy. Radiation therapy can be conducted as conventional radiotherapy, fractionated over 25 to 30 sessions, or as stereotactic and fractionated single dose radiosurgery. Mean remission rate of 80% is obtained, no recurrence rate, and the median time to remission of 8 months. New hypopituitarism is a common problem in up to 38 to 40% of patients. Other severe side effects are rare for radiotherapy. Optic neuropathy, neuropathy radiation included second tumor, and the 10-year survival rate was very high. A combination with medical therapy is always required to bridge the time between radiation and remission. Effective medical control should be proven before initiation of radiation therapy. Medical therapy: many drugs may be combined with each other. Pasireotide and cabergoline, steroidogenesis inhibitor, metirapol, ketoconazole, metotan, and etomidate, and mifepristone. They are the first choice in emergency situation with severe hypercortisolism. Medical therapy is also an option for patients who are not suitable candidate for surgery due to comorbidity. The last treatment is bilateral adrenalectomy, considered as an emergency option in severe and uncontrolled hypercortisolism, or as a last option when other treatment options are unsuccessful or not well tolerated. Bilateral adrenalectomy is the definitive therapy with a success rate of 100%, but Nelson syndrome and permanent adrenal insufficiency are seen in 8 to 29% of cases. The need for lifelong hydrocortisone and fluorocortisone replacement therapy with the risk of having adrenal crisis. The recommendation for pituitary surgery in Cushing disease: patients with Cushing disease undergo surgery as primary therapy in specialized pituitary tumor center of excellence. Surgery should be performed by an experienced pituitary neurosurgeon and follow-up done by a multidisciplinary team, including a pituitary endocrinologist. If the original procedure is unsuccessful, reoperation can be considered. In cases of recurrence, we suggest repeat transfemoidal surgery in patients with biochemical evidence of recurrent Cushing disease, especially if tumor is visible on MRI. This is the algorithm. For persistent of recurrent disease, we should the treatment done by interdisciplinary tumor board, and we have 4 options. Second, reoperation, transfemoidal surgery, radiation therapy, medical therapy, and last, bilateral adrenalectomy, which give us 100% success rate. This is also an algorithm. And as a take-home message, Cushing disease is a rare and complex disease, should be treated in an experienced center with an interdisciplinary tumor board having proven their worth. We should consider also MRI 3 Tesla with methionine PET to do the diagnosis for in 100%, because it can do the diagnosis in 100% of cases. And the transfemoidal surgery actually is the first line treatment. And we should do annual clinical screening which is recommended because of the recurrence, and the recurrence is a common problem seen in the first year in 15% of cases, and treatment decision requires high level of expertise and should be done by a multidisciplinary team. And in case of recurrence of there are many options: second surgery, radiation therapy, medical treatment, and at last bilateral adrenalectomy. And thank you for your kind attention.
Thank you, Professor Mehdi. Any question or comment? Thank you, Professor Darmol, again.
Thank you
for your excellent presentation. Now we can move to our next speaker, Professor Pablo Argeler from Argentina. His presentation is on anterior petrosal meningiomas. Professor.
Hello, do you hear me?
Yes, your voice
Do you hear me?
Yes,
Okay,
you're audible.
perfect. Do you see my screen?
Yes.
Okay, perfect. Thank you very much for this invitation. It's an honor for me to be here at this multi-language, multi-countries World Congress. Thank you, Sameh. I will talk about anterior petrosal meningiomas and what we do in Buenos Aires at the Department of Neurosurgery here in my hospital, Hospital Italiano of Buenos Aires. And we know that the treatment of this tumor is always a challenge. So despite of the evolution of images, surgical techniques, and neurophysiology, morbidity and mortality remains quite high because there's a lot of important neurovascular structures around that area. So when we see the anatomy of the area, this is the area, we find the trigeminal nerve posterior, anterior, the internal auditory canal posterior, the sixth nerve, the third nerve here in this anatomical view, and tumors are there between anterior exactly to the internal auditory canal. And this is the trigeminal nerve. When we see the brainstem, tumors always are in this area. So we lead with lower cranial nerves, 7 and 8, trigeminal nerve, 6th nerve, and 4th nerve in the upper part of tumors. Just to talk especially about the difference between anterior petrosal tumors and petroclival tumors. Petroclival tumors are usually anterior to the trigeminal nerve. Trigeminal nerve is here. So anterior petrosal tumors are anterior to the internal auditory canal and the trigeminal nerve. So here are petrosal tumors and petroclival tumors are more anterior and different. There's a lot of papers confusing a little bit what is a petroclival meningioma and what is a petrosal tumor. And this is a petroclival tumor. Why? Because you see that the trigeminal nerve is there and the tumor always grows through the brainstem, like this. When we see an anterior petrosal tumor like this, you can see that the trigeminal nerve is medial and the tumor grows to the cerebellopontine angle, not to the brainstem, more to the middle peduncle, as you can see. So here you have here this is an anterior petrosal and this is a petroclival tumor. And these tumors are really different. We can see in this beautiful paper that the arachnoid layers are different, are more easy to operate the anterior petrosal tumor than petroclival tumor because petroclival tumors only have one layer of arachnoid with the brainstem, and anterior petrosal tumor have more than one layer with the brainstem, so they're more easy to dissect. So what is important to make the best resection with no morbidity? How to select the approach? The selection of the approach depends on the extension and location of the tumor, the size, and relation with the clivus and the petrous bone, relation with the tentorion, involvement of vascular nervous structure. This is the things that we take into account to decide the correct approach. These are the options: retrosite, anterior petrosal or Kawase approach, and posterior transpetrosal. I prefer for most of these tumors the retrosig approach, and I will show you how we do it, the dissection, the exposure of the transverse and sigmoid sinus. This is very important to enter exactly to the tumor. Then we open the basal cisterns in order to relax the cerebellum. So we open the dura, the cerebellum is relaxed, and we don't have no damage to the cerebellum. Then we retract a little bit the cerebellum, and we see here the tentorium, petrosal vein, trigeminal nerve, 7 and 8. The tumor is here, there. The tumor is there. So this is with a lower view. We can see here the lower cranial nerves, the internal auditory canal with the 7 and 8. Here is the trigeminal nerve, the petrosal vein, and vascular structure, the superior cerebellosum artery here, the ICA and the PICA. And sometimes when the tumor involves the trigeminal porus, we can drill the suprameatal aspect to gain more access, many times to the vascular side, the meningioma. The advantage of the retrosig is that it's simple, usual, and less time for doing the approach. The disadvantage may be the tumor desvascularization, because when you go through a posterior transpetrosal, maybe you can resect the dura and devascularize the tumor. And you have to operate through the nerve. So I will show you some cases. This is not exactly an anterior petrosis, more a petroclival tumor, but this is very common. A case, this was a girl, I will skip a little bit, 63-year-old female with a trigeminal neuralgia. So you can see the MRI, the tumor, small tumor, as you can see, more tentorial tumor, but in that area. So we go through a park bench position. I sometimes operate through park bench and sometimes semi-sitting position. And this is the surgery. We coagulate a small branch of the petrosal vein there because the tumor was here, and here is the trigeminal nerve. So we get with this more space to attack the tumor. And then here we see we dissect the nerves. It is very important to know the anatomy perfect, and then go to the tumor. We dissect the trigeminal nerve from the meningioma. The meningioma was anterior to the trigeminal nerve, so this is a petroclival, small petroclival in the anterior petrosal area. And we dissect the trigeminal nerve from the tumor, and we start coagulating the insertion of the meningioma in order to, there's the 6th nerve there. I skip a little bit. You can see here the anatomy of the area. So we start making the debulking of tumor. As you can see here, the trigeminal nerve, here the tumor. And we go piece by piece in order to skip a little bit. And you can see here how we are finishing the resection of the tumor here, the brainstem. We coagulate, we resect the tumor. We try to have a clean view all the surgery. And we're taking out the tumor now. And then we take this small piece that go through in the trigeminal porus there, going to the middle fossa. We resect that part of the tumor, and this is the final view. The trigeminal nerve totally free now. No tumor there. Lower cranial nerves, 7 and 8, and lower cranial nerves here. And this is final view, as you can see. Here you can see the control MRI with no tumor in axial view. And coronal view, T1 with gadolinium. You see that we have no tumor there. So this is the first case. This is the post-op. Another smaller case, I will show you very fast this because it's very similar with neuralgia, with trigeminal neuralgia. This was a 53-year-old girl. This was very small tumor, as you can see there, very similar, very small. So we go through a retrosig, as I show you, and then we dissect all the structure there, and there was the tumor. It's very small, just anterior to trigeminal nerve there. And this was really easy because the tumor was very, very small. The patient had treated with tegretol, but with no response. So we go through the resection of the tumor and skip a little bit, very similar to the other surgery I showed you. Here you can see the forenerve, and here the tentorium, here the trigeminal nerve, and we take the tumor from that for superior part of the trigeminal nerve. I skip the surgery because it's very similar to the anterior surgery. This is the final view. Final view. You can see now at the end of the surgery, very small craniotomy, 3 centimeters. We resect the tumor, and this is the control pre and post-op MRI, pre and post-op MRI. Let's go to big tumors. This is a 38-year-old female with headache and facial numbness, and you can see this big tumor that goes infra-supratentorial. As you can see here, it's not only anterior petrosal, it's posterior petrosal also. Look where is the internal auditory canal here. So we operate this patient in a semi-sitting position, as you can see. This is our OR. So we move the cerebellum here, and we expose the tumor. The tumor is here. So we start these surgery, longer surgeries. We use a lot ultrasonic aspiration to debulk the tumor, so we can remove it and dissect it from the brainstem. As you can see here, we are moving the tumor. You can see the arachnoid layer here. Very good arachnoid layer because it's an anterior petrosal. It's different from petroclival. And we take the tumor out. We use again ultrasonic aspiration. We find the seventh nerve here. So we dissect it with magnification, a lot of magnification, and we dissect it from the tumor. We try not to coagulate around the seventh nerve. We try to take the tumor out from the superior aspect in order not to damage the lower cranial nerves. And we are dissecting now the tumor from the brainstem. I skip a little bit because the video is a little bit long. We finish the dissection from the seventh nerve. We coagulate the tumor now. As you can see, we continue the dissection, cutting the tumor, ultrasonic aspiration. Then you can see we are taking out all the tumor there. That is the brainstem. We are dissecting very adherent because it was a big tumor. And we are finishing now the surgery. As you can see, ultrasonic aspiration, then we see the brainstem there, and we will find finally the trigeminal nerve. Here is the seventh nerve. The trigeminal nerve is in the upper part of the view, and this is the post-op MRI with no tumor, post-op MRI. And when we preserve the facial nerve, we have to wait. You can see that there's no tumor there, and if you wait, the patient recover practically all the facial nerve with very good control, and the patient is cured. Another case, 62-year-old girl, again, big tumor with this invasion over the brainstem and the cerebellar peduncle. And here the rest of the pre-op MRI. Pre-op MRI, look how the compromise the internal auditory canal. We operate this patient in the park bench position. Again, we first take CSF out, we recognize anatomy, and then we start to debulk the tumor, coagulate the implantation, take the tumor out. We go first to the upper part of the tumor, then we dissect it from the brainstem. We coagulate the tumor in order to work better. And you can see here the 7 nerve here, 7 and 8. We have tumor here, lower cranial nerves. The tumor is up and inside and below the 7 and 8. And we dissect them from the lower cranial nerves. And we take all the superior part of the tumor out, and then we bring the lower part of the tumor from the upper part, leaving the 7 nerve here. We coagulate and cut the tumor there. And this is the final part. We're taking the tumor, the rest of the tumor, and coagulating the insertion of the tumor. And this is the final view with all the structures. This is a long surgery, but with very good result if you go step by step. And this is the final view of the surgery. And you can see here the control MRI with no tumor, control MRI, coronal and sagittal view. The patient in the immediate post-op with a palsy, a fascial palsy, and then 3 months with the total recovery of fascial palsy. Another view of immediate post-op in the left, and 3 months in the right. Another case, a big case with middle fossa. I know this was not with middle fossa. Very similar to the anterior cases I show you. Again, park bench, retrosig. We take CSF out. We start with the ultrasonic aspiration. We debulk the tumor. We identify the 7 nerve there. So we expose the 4 nerve. We expose the lower cranial nerves. Here you can see the 4 nerve. So we continue to treating the tumor when we identify the nerves. When you can see there, nerves 7 and 8 here. Ultrasonic aspiration again, dissecting the 7 nerve, dissecting the tumor, superior and inferior, dissecting the tumor from the brainstem, always the same. It's a meningioma, so we use the same technique we use for another meningiomas. Then we identify anterior, the trigeminal nerve here, implantation here, 7 and 8. Anterior petrosal tumors are here. 5th nerve, 7 and 8, and lower cranial nerves. This is the final view, the 6th nerve there, final view, and control MRI with no tumors. As you can see, no tumor. Another case, this is with petroclival extension. I operate this patient in a semi-sitting position, big case, semi-sitting position. Again, I show you one case in a semi-sitting position. We coagulate the tumor with the bulk tumor. We cut the tumor. Always the same. Identifying the nerves. We always use intraoperative neurophysiology to check the brainstem, check the fascial nerves, check the lower cranial nerves. With the neurologist in the operating room, we take the tumor out. It was a little bit more bleeding. We always do the same, ultrasonic aspiration, more ultrasonic aspiration in order to debulk the tumor so we can mobilize. You can't move the tumor if you do not debulk it. You have to debulk it first and then move the tumor, coagulating the tumor to shrink it. As you can see, we are finishing now the resection. You can see there the 7 nerve here, as the other cases I show you. And this is the technique we use. Microsurgical technique, following the principles of Professor Yasser here, Professor Al-Mefti, always the same. Microsurgical technique. We leave a little piece of tumor in the middle fossa. We can reach it from below, from the retrosig approach, but this is the control MRI. This is the patient with no fascial palsy. We can resect this tumor with no morbidity. Another case with medial extension, pre and post-op. You can see superior the tumor here, the post-op. Another case with petroclival extension. We have a lot of cases, a 73-year-old female, And here, the patient had hemiparesia previously because it had edema in the brainstem. This is a bad prognosis thing when you find it in the MRI. But we go to the surgery, we do the same. In this case, you can see 7 and 8 here, tentorium here. We take the tumor from the upper part of the 7 and 8, we coagulate the tumor, and we resect it with catching the tumor, ultrasonic aspiration, the bulking of the tumor, dissecting from the brainstem. Again, look, the brainstem here, it was really adherent to the tumor. It was difficult to dissect, but we can do it. We continue with resecting the tumor, as you can see, preserving the neurovascular structures. As you can see, again, ultrasonic aspiration. Always the tumor is inserted here. 7 nerve here, trigeminal nerve here. Here is the implant of the tumor. There you can see the trigeminal nerve. So the implant is here. This is an anterior petrosal tumor. If the implantation is anterior to the trigeminal nerve, it's a petroclival tumor. Pre and post-op, as you can see, I think this is the last case I will show you. So my final considerations, the suboccipital approach is a very useful alternative in these cases of anterior petrosal tumors with no so much invasion to the middle fossa. If you have a lot of tumor in the middle fossa, maybe you need a transpetrosal subtemporal approach. The coagulation of the petrosal vein at the beginning of the surgery of the posterior part of the petrosal vein, because sometimes there's an anterior part, give you more access to the supracerebellous approach. And that's very good for this tumor. And the transpetrous access is reserved for those tumors divided, as I told you, the middle fossa and contralateral clive. Thank you. I hope it was okay. You hear everything?
Yes, Professor Pablo, it was an excellent review of Petrus' approaches. We thoroughly enjoyed your presentation.
Thank you very much.
Any question or comment? Do you come across any bipolar related cranial nerve thermal injuries? And the second part of my question is that any vasospasm of vessels during the manipulation? Any experience?
When I have a little bit of vasospasm, I use papaverine. When I finish the surgery, I have no problems with that. The first question was about the bipolar. You asked me what about bipolar? I don't understand. I'm sorry.
Yes, thermal injury effect to nerves because of using bipolar or diathermy in the vicinity of cranial.
When I work close to cranial nerves, I use the bipolar very, very low. I try not to use it only when I have bleeding. Maybe sometimes from the anterior part of the internal auditory canal, I have some bleedings there. I try to stop it with a cottonoid and with a Surgicel. If I cannot do that, if I have to coagulate, I put the bipolar very low. Hola, Jorge. Hello.
Thank you so much. With this excellent presentation, now we move to our next speaker. So, Professor George Mora from Chile. His topic of presentation is extradural mini-temporal approach, the cavernous sinus finally unlocked, is the title of the presentation. Professor Mora.
Yes, hello. Can you see my screen?
Yes.
Yes.
Excellent. Excellent. Thank you for the opportunity to talk today. I will I will try to show you in 20 minutes some aspects of a variation of the classic middle fossa approach, and the approach that we're using now for 10 years to treat a variety of different lesions in the cavernous sinus and through the cavernous sinus to posterior fossa pathologies. First of all, I always thank Dr. Evandro, Elder, and Wen, who teach me in my fellowship in 1998 in Brazil. And starting with it's always good to start to talk about cavernous sinus with the paraclinoid aneurysm, because it's the most simple pathology that you can treat in the region. This pathology was addressed for several neurosurgeons, and we must understand why the North American neurosurgeons are used to treat the patients with subdural craniodectomy, because the subdural craniodectomy was introduced in 1968 for Charles Drake for London, Ontario, Canada. And the extradural pure version was started for Akira Hakuba in 1982. And we have a combined variation that was introduced in 1983 for Vinco Dolens. These three kind of surgeries are completely different, and their indications, their results, the technical difficulty, and the knowledge that you must have in order to can do this. The most easy to do is the subdural, of course, because in the subdural version you see everything. But the compression that you can achieve with the subdural is the most vascular oriented. The extradural, you can achieve complete decompression, but you need to deal with the cavernous sinus lateral wall. And then you must have more knowledge in order to use the cavernous sinus. And the combined one is, or hybrid version, who were introduced by Dolens. You use both philosophies, and it's good for any kind of lesions. That's why Dolens published aneurysm, meningiomas, chondrosarcomas, trigeminal and all kind of pathologies. And it's very interesting because the main difference between the Japanese philosophy and the Dolens philosophy is in the Japanese you don't need to use drill. You can do all the surgery just with rangers, no drilling. Of course, if you need to take out the anterior petrous bone, you need drilling because it's impossible with rangers. But in the rest of the bone work in this kind of surgery, you can do with the anterior craniodectomy and posterior craniodectomy just with rangers. I studied a lot this subject in 2000 when I entered to my society. I used the Dolens approach for the first cases that I operate in paraclinoid. Now I have almost 500 paraclinoid treated, and in that time I have 8. This is for the young people whom I must say that there's no genius in neurosurgery, just persons. And if you do hard work, you study neuroanatomy, and you devote yourself to the treatment of pathology, you can achieve everything. It's not for genius. This is for just regular people. Even there's some ones who believe they're genius. Maybe there's a few. And I have the luck to knew Akira Hakuba in 1996. If you see the figure of his book in the upper diagram, you see it's almost the same that the dissection that we made in Stanford with Maxi Núñez from Argentina. The below dissection is of course made with microscope, but the philosophy and the anatomical knowledge is the same. And then in 1982, everything was described for Hakuba. Now like I said to you, we have 488 aneurysms paraclinally because I operate one this week. And in half of the cases, you can take subdural decline without problem, but for the rest of the aneurysm, it's more advisable to take all the cavernous sinus and open widely. We did the same surgery, the classic surgery, for 15 years, since 1999 to 2014. But in that time, we think we need to change to less invasive approach. And we base our surgery in the mini-pterional approach. We don't have time to discuss now, but there are several advantages of the Mediterranean approach. Of course, we publish all of this in paraclinoid, in sphenopetroclival meningiomas. Up to date, we have 89 cases of sphenopetroclival. My series is 160 petroclival in total, but the typical simple petroclival you can take for retrosigmoid approach, I agree with that. But the most complex one who have a component in the middle fossa or in the pituitary fossa is more advisable to came from the middle fossa because you can see the nerves in front of you and you can dissect completely in the lateral wall of the cavernous sinus as we learn in the non-meningeal pathology. We published the most basic version of the approach in 2020, who is the Mediterranean approach. We can use this in paraclinoid and in clinoidal meningiomas, but for the most complex meningiomas, you need to have wider exposure. And then we came with this name in 2015, 2016, because we don't know how to put the name of this, because we try to do mini everything, mini Hakuba, mini Kawase, mini Dolens, but we need to put all together because you need to be conceptual in order to make your surgery reproducible. Because if you are just a good surgeon and nobody can do what you do, this is not good for the patients. You need to be reproducible in your technique. And then we use as a base in honor to Dr. Evandro, the pretemporal approach that he described 30 years ago. But you see this approach is based in a classical pterional, and the other thing is subdural. You need to sacrifice the anterior venous system in the temporal lobe. That is a problem because one of the problems of the middle fossa is the brain swelling. For me, I'm convinced it's secondary to the venous sacrifice that you need to do. Then you need to deal with this and do a new philosophy in order to treat the veins. It's very important. And the other thing is the pathology that we're going to treat. We start treating the sphenopetroclivals and always based in anatomy. This is a mini pretemporal concept that we published in 2015 this year. This is a modified Mediterranean approach. And I want to show you because we don't have time that this is new. We have only 3 references in mini pretemporal, 109 in Mediterranean, and you see that this started just in 2007. It's very recent, all the experience of this. And our last paper published 2 weeks ago is about how you're going to reconstruct this kind of surgery because nobody talk about the subject. I can show you 100 MRIs or angiography of patients operate without tumor. But the important thing about the patient is how you deal to open, how you deal to close, and how is your patient after the surgery. That's the more important thing, the functional result. Then we published this in the how to do the surgery in neurosurgery. We have this video in the operative neurosurgery made for Arnaud Benet, a brilliant neurosurgeon who worked in the United States, was resident of Michael Lawton. This is QR code in order to can download this video. And of course, we base in the experience of Dr. Vandro. But if you see this video of 1998 that I have when I was fellow in a clipping of low-lying this was a paraclino aneurysm. You can see the combined technique. The combined technique, you open the dura, you didn't open the meningo-orbital band, who is the key in order to make the dissection of the group of veins in the tip of the temporal lobe. This is very important because if you cannot dissect this vein, you cannot open the cavernous sinus completely. It's very important that. I'm going to stress you because it's the most important thing. Of course, we have authors who work in the classic way today, like Sam Su for Taiwan. He's a brilliant surgeon who can do the transtereal approach very similar than the way that we do, but based in an orbitozygomatic approach. We stopped to use orbitozygomatic approach in 2008. After that we can operate all kind of lesions without made orbitozygomatic approach, and we can talk about this controversial point, but I can show you any kind of cases, no retraction damage, even no retractor in the surgery, and no need to use the orbitozygomatic approach. And this is the paper of Sanford Su, very interesting, the transmecal cave approach that he freed all the nerves in the lateral wall of the cavernous sinus. And if you see the experience of different authors like Al-Mefti, Sami Kawase, De Monte, Shekhar, Will Caldwell, Al-Mefti, if you made the levels that the Sanford talk, the series are 100, 200. We in my country, we have, if we put together our experience up to date, and we have 323 of these cases. Mainly are, of course, the tuberculum cella, the cavernous sinus, petroclival, middle fossa, and everything. This is why my country is only 22 million patients, 22 million, inhabitants. But the good thing about my hospital, we have a 100 beds facility, and we receive all the country in the complex cases because we have fellows in every city. And then the most complex cases came to me, and the regular cases are managed for the rest of the neurosurgeons. And it's very important to have this concept about the reference centers in order to have good results. This is a little about history of the approaches, and I want to make honor to, of course, to Edgar Natal, Figueiredo, and Peter Nakaji, and Rafa Martinez, who described the mini pretemporal recently. These are the dissections, very beautiful for Maxi Nunes, and you can see in these dissections the treatment in the lateral wall of the cavernous sinus. The new concepts that I can tell you that are a little bit different of the classics are the splitting of the tentorium. The splitting of the tentorium make you possible to dissect the fourth nerve safely. And this is one of the most important differences with the classic approaches, because in the classic approaches, the fourth nerve is always leave with the sleeve of dura mater surround. This is not needed. You can dissect completely. And the other thing, you can take the dura between the third and the fourth, the third and the fifth nerve in order to get the posterior fossa. It's very easy to do. And in the basilar artery, you can expose up to the VV junction in vascular pathology. The other thing important in the case of meningiomas, if you treat the Parkinson triangle, you can coagulate the irrigation of the tumor prior to take the tumor. Then avoid the necessity of use bipolar related to the nerves, because the bipolar, as the colleague previous question, is very important not to coagulate over the nerves, because if you coagulate, the compromise of the nerve will never recover. It's even better cut the nerve and make the suture, neuroraphia, after the surgery, that if you coagulate, the damage is not going to recover. And then if you take all the dura, you have this kind of exposure is the same in the actual patients, but the problem is how you're going to close. We will talk a little few words about this. This is the final view, and I want to stress in this slide the most important thing, that is the petrous bone, the petrous apex, is nothing to do with the Kawase triangle. The Kawase triangle is only the half of the problem. The other half of the problem is below the fifth nerve. And then you need to mobilize the fifth nerve in order to, you can see all the petrous bone. And in that case, you can expose the sixth nerve since the entrance in the Dorello canal to the orbit through the middle fossa. It's very important. And the other thing, you can expose all the posterior circulation since the VV junction to the basilar tip in any kind of vascular pathology. This is the final view. If you put endoscopy in the case of we are talking about, is even better the view than you have. You can treat lesions up to the foramen magnum through the middle fossa. We already treat lesions like that. We're going to publish, of course, because this is always a little controversial, how you can, how below you can reach for the middle fossa. But you need proper instrumentation. We develop special rongers in order to can do this kind of surgery. And I always remember this paper of William Caldwell, who was the first one who put the numbers at the same level of Dolenz, Hakuba, and Kawase. This is very important because the acknowledgement is very important when you treat any kind of pathology, because we must be historical accurate when we talk about this kind of surgeries. That's why I take this picture with him when we were together in Turkey. I'm going to skip this video because I want to show you only two concepts. The venous treatment is key in the middle fossa surgery. Nobody talk about this, but it's very important. We must know how we need to deal with the venous system, because all the swelling is coming from this. In 150 cases that I have up to date, I only have one brain swelling because we modify the previous techniques in order to treat the venous preservation. And we base our paper, our work in a paper published recently for Arnau and Rokuya with Michael Lawton about the venous system. We must know that when the venous system, the profound system of basal vein of Rosenthal is very well developed, the superficial system is small. When we have a very bad developed profound system, the venous system in the surface is very, very big. And then in that cases, we must to be careful. And then I want to show you just this little video because here you can see what happened in most of the meningeal pathologies. We have the occlusion of the venous drainage to the sphenoparietal sinus. What we do in these cases always is put a clip. Why? Because it's very important to avoid the retrograde coagulation of the venous system. Because when you have occlusion of the system that drain the temporal lobe, the patient develop anastomosis, like always in any pathology. And you can see the big hole in the lateral wall of the cavernous sinus, but we preserve all the connections between the frontal lobe, the temporal tip, the anterior temporal veins, the basal veins of Rosenthal, and everything. And look at how big is the opening. But in 89% of the patients, the venous drainage to the posterior system of labea and trolar is preserved. And then that is very interesting. When we coagulate this huge vein, huge drainage, we avoid the retrograde coagulation because we use a clip, and the clip avoid and the system were compromised. After that, you need only to separate the exophytic portion, in this case, a lateral wall of the cavernous sinus meningioma is already made the peeling. And you can see there the Parkinson triangle, the third, the fourth, the intracavernous carotid artery, and we are taking out this tumor. And after that, the most important thing you can achieve in some cases, Simpson 1 in this kind of it's not usual, but in this case we can achieve. We see the fifth, the fourth, the third, the carotid, the optic nerve, and the intracavernous carotid artery, the port nerve preserved, and the basilar artery. All the tumor is gone. This is a Surgi cell in the Parkinson triangle because I don't want to put so many Surgi flow inside the cavernous sinus. But if you see this, that is more important is the venous drainage. I want to stress you how the venous system go to the Labé system, but for the Sylvian vein, and you can see the drainage of all the temporal lobe, no retraction, no brain swelling. Very important this. It's very important this. You need to leave, in other cases, a flap of dura to preserve the connections between the veins. The other thing is the closure, the Rafa flap. This was published a few days ago, and it's very important because we cannot how to close in the anterior portion because we take the dura because you need to think that 70% of the cases are meningiomas, and then you need to resuck the dura propria. And then how are you going to close? Nobody said to you how. No artificial flap, temporal flap, gallial flap. No. We develop a special flap. You need to develop special things for a special surgery. And then this is my fellow that I encourage my fellow to close with the microscope. They are closing in this case. And I open always I open linear opening of the dura. This is the frontal side. This is the temporal side. This is a mini pterygium approach. This is the superficial Sylvian system. This is the middle fossa. We close this. I'm going to skip because we don't have time. But just to show you that we have a flap that came from the front that is based in the anterior portion of the surgery, and then you just close the anterior portion of the dura with this pediculate vascularized flap, and you just close with the muscle, with the dura in the frontal side, you can have a watertight closure. You put after that the bone flap in over all of this, and we stop the pseudomeningocele, the CSF leak, and everything. This is brilliant flap developed for Rafael Martinez Perez, who is a fellow of mine. Now he works in Gaisingale in Pennsylvania, Estados Unidos, United States. Sorry for speaking in Spanish. And only I'm going to show you one video because we don't have time. This is the final view just to show you that we have 156 cases. This is a craniopharyngioma. But look at the final view in this surgery without taking the anterior petrous bone, nothing. This is the optic nerve, right side, left side, superior epiphyseal artery, distal dural ring, carotid artery, PCOM, anterior choroidal, third nerve, posterior vein of the carotid artery, fourth nerve that I mobilize and I put together with the fifth, basilar artery, superior cerebellar, contralateral superior cerebellar, ICA. This kind of view you can reach with this kind of surgery without retraction, no retractors. And this is my bipolar just to compress a little bit and see what happened. These are the different levels of the miplata. We don't have time to talk about this, but I'm going to show you, this is not, I think this is too much. I'm going to show you a vascular case. The vascular cases are the more simple cases to treat. This was a patient of 70 years old. The interesting case of the patient was she had a third nerve palsy for 6 months. But the problem that the aneurysm, the posterior cerebral artery, was coming from the aneurysm. Then we discussed about the flow diversion in this case. But the problem was if something happened with the posterior cerebral artery, the patient will only have, after the surgery for sure, half eye because have hymenopsia and the right eye have a complete third palsy for more than 6 months. Then we discuss with the patient and we offer to her that we can preserve the posterior cerebral artery with the surgery. And then we will try to decompress or reconstruct the third nerve in this case. We operated her 3 or 4 months ago. We are still waiting because we need 6 months at least to see any recovery of the third nerve. I discussed a lot this with other neurosurgeons, and all of them said to me that the third nerve is not going to recover, but we are still waiting. But I can say to you very happily, the patient have complete normal left eye. And then here I'm showing to you the extradural dissection. You can see the fourth nerve in the extradural portion. This is the coagulation of the meningopophyseal trunk. This is the opening of the dura. I prepared the STA just in case for doing a bypass. The same treatment of the pure drainage with clipping. The opening of the sylvian fissure that is typical from the vascular pathology. This is the MCA. This is the proximal MCA. This is we are going, reaching the carotid bifurcation. This is the fourth nerve that I'm dissecting. Now I'm connecting the dural opening between the fifth nerve and the third nerve. And you will see that we can have a wide exposure of the posterior fossa. We can see in a few moments the basilar artery. This is the fourth nerve. I put a clip to put the fourth nerve together with the fifth because I don't want to make a lesion. After that, I dissect extradurally the third nerve. I made an icy green. You can see here the aneurysm. The aneurysm, a portion of the sac was very strictly related to the distal dural ring. This is the anterior choroidal. And now I open in the distal dural ring of the carotid artery. And why I open the cavernous sinus? Because I want to have control proximal to this carotid because have a heavily atherosclerotic disease, the proximal carotid. You can see there the temporary clipping. The sixth nerve is right in the right side of the clip blades. I have proximal control. After that, I put distal control. First clip, I mistaken, I put in anterior choroidal. I correct the clip, and this is in the anterior cerebral. This other clip is in the posterior cerebral artery. When I have a efficient trapping of the lesion, I free the anterior choroidal from the sac. Is completely freed from the sac. Why? Because we need to put a clip. Here you can see the distal dural ring related to the sac, the basilar artery in the bottom. It's easy to see the basilar artery in this kind of surgery, the distal portion for any distal basilar tip aneurysm. And then we are freeing here the third nerve. The third nerve was completely destroyed for the pathology. That's why the patient have this complete third nerve palsy. Then I use a 18 millimeter semi-curved clip, Peter Lasik D clip. They're very good clips. And then the goal of the surgery is the preservation of the anterior carotid the internal carotid artery, the anterior choroidal, and of course the posterior cerebral artery. This is a very nasty aneurysm with very heavily compression of the all structures, but we must remember our goals in the surgery. Okay, I advanced the clip a little bit because I want not feel comfortable with the preservation of the posterior cerebral artery. You can see the posterior cerebral artery contralateral in the bottom of the surgery. After that, I take out my temporary clips and my proximal temporary clip. The posterior cerebral artery was preserved, a little bit kinky in the beginning of the artery, but it's patent in the icy green. Everything was patent. The monitoring was normal. And then I put again a clip and I made a decompression of the aneurysm. I'm going to skip this because it's not interesting. And I'm going to show you that it's very important when you have good control of the pathology, you can do what is needed. In this case, decompress the sac. Now you have plenty room to see the third nerve because the goal was reconstruct the nerve. And remember that in this case, I really want to do a reconstruction of the third nerve in the right side. This is the basilar tip. I put a second clip. Remember that the neck of the aneurysm is very big. And I put this second clip, but it was not good enough. And after that, I put a third clip. And you can see I made in the suture of the third nerve. I can make a very nice reconstruction of the third nerve. And we are still waiting for what happened with this patient. But look at this. I have to remember to you that this is a mini pterional approach. It's a craniotomy of 3-4 centimeters, no more than that. And then this is skull base surgery is not about the craniotomy. Skull base surgery is about the bottom of the surgery, and the bottom of the surgery is the dealing with the cavernous sinus. That's the key. Finally, I clip a MCA that the patient have in the same time, in the same site, sorry, and everything did well with the patient. She had preservation of the posterior cerebral artery. You can see here the use of the superficial flap, and we can close watertight the dura mater. And just to finish my presentation, I want you see the post-operative CT angio. The most important, of course, the preservation of the internal carotid artery and the posterior cerebral artery, even more important than anything we talk. Because if you cannot deconstruct the posterior cerebral artery, it's better to put a flow diverter. But we believe that microsurgery still have something to say in this kind of lesions. We have another kind of pathologies, trigeminal schwannomas, craniopharyngiomas, basilar tip aneurysm, superior cerebral artery aneurysm, brainstem cavernomas, a lot of things. But I want to finish that we can work together with endoscopy. We must work together with exoscopy. In these cases that I show you here, you can see the VV junction in the picture. Without any retraction, you can see the VV junction for the medial fossa because you can take all the temporal bone for the medial fossa. We will publish in a couple of months finally the use of medial fossa to drill all the temporal bone from the front up to jugular foramen. You can do all of that. Epidermoids, whatever you want. And this paper was published in September 16 about the use of this approach and the dissection that I showed you of the fourth nerve in the transorbital endoscopic approach. We will work with this with Ricardo Carrao, with Doug Kong, and Professor Daniel Prevedelo, because it's, for me, the orbital surgery have future in this, but we need to do proper instrumentation and proper dissection. Thank you very much for your attention. I want to be thankful for Professor Shrivas that we published this book of the World Federation, and I was lucky to contribute with the MiPlata approach in the complex cerebral aneurysms. And we show several cases in this book. You can see in the book with videos and everything about the treatment of giant paraclinoid and other kind of aneurysms. And I think that, as I said before, that the MiPlata approach is a versatile, modifiable, anatomical landmark learning curve, and we can use the cavernous sinus in order to treat very complex lesions. Thank you to my fellows, and thank you for your attention.
Thank you, Professor Mora, for amazing details. amazing. Do we have any question or comments for Professor Mora?
Yes,
Okay, thank
can I?
you, Professor. Sure, please.
Yeah,
Sure,
can I
please.
make a comment?
Yes, sure.
Okay, I want to congratulate Dr. Mura for his excellent results and the apply of this approach to tumoral and vascular lesions. I think that at present, most of the aneurysms can be treated by minimal invasive approaches. And I congratulate Dr. Mura for his great effort that has he made in favor of all neurosurgeons all over the world. Thank you.
Thank you, Professor Natal. ¿Cómo está? For me, it's an honor the remarks of Professor Natal because he's one of my. I always say to my fellows that you need to have heroes, and he's one of my heroes. I follow him for a long time. He's older than me, okay, but I follow him for a very long time, and I always try to follow his philosophy about we can do great surgery in minimal invasive approach. Minimal invasive is completely different of minimalism. We are not talking about minimalism surgery, no. We are talking about a small surgery well done. You don't need to spend time in something you are not going to use in surgery. Dr. Natal is an expert on that. I try to do that, but I cannot get it. But he's an expert in because he used 100% of the exposure in the patient. And of course, for me, it's very important his remarks. And of course, I thank the honor to what he say about me. Thank you.
Thank you again, Professor Mora. We are running short of time. So can we move to our next speaker, Dr. Sanjeeva Jayratna. His topic is retrosigmoid craniotomy, skull-based workforce.
Thank you very much. And I thank you for the invitation. It's always a great meeting to be here. And I really enjoyed that last talk. I thought it was an excellent talk and really nice to see Professor Hakuba and Professor Oliveira mentioned there, whose work I really admire as well. It's a great talk from the last speaker. I'm going to talk about something a lot more simple, which I think is very applicable to everybody, and that's the real workhorse approach of the retrosigmoid craniotomy. So I'll just minimize the Zoom window. Great. Okay, so these are the kind of cases as a skull-based surgeon that you have to deal with. All of these could be done via retrosigmoid. I'm sure you've heard me speak before. You know, for example, this case on the left here, we'd favor a combined petrosal. And in some cases like this one here on the bottom right, which are both true petroclivals, because of the biology and the sort of involvement of the brainstem, whatever approach you take is very difficult. But for the rest of these cases, say this petrous, and I don't consider this a petroclival, I'd say that's a petrous meningioma, which I should probably show that case. Large vascular vestibular schwannomas. The retrosigmoid is a workhorse approach, and really one we would do, lots of retrosigmoids each week here in Oxford. As always, I love this slide. I've been showing this slide for years. If you're a trainee, you have to learning neurosurgery, you have to understand what each approach gets you. For us, and I really enjoyed that comment in the last talk, and I know people like Professor Mora, Professor Ipcherian will use anterior petrosectomies and get very low. But for most people, the IAM is sort of the limit, and that's how we still think about it. I understand you can get much lower, but the IAM is really your limit for most people with an anterior petrosectomy. And quite rightly, like the last speaker said, you must drill well beyond the trigeminal depression to really get into the clivus. I'm going to talk about the retrosigmoid today. It's a workhorse approach, complete panoramic view from the tentorium all the way down to foramen. You can extend it with the far lateral. Amazing view. You can go supracerebellar if you cut the tentorium. I probably won't show any case like that today, but absolutely workhorse view. We use it lots of times every week. Far lateral, of course, is for craniocervical junction. Unless you combine it with the retrosig, it's hard to see above the jugular foramen. And we're big fans of this, the transpetrous transcentrale. I've spoken about this before. but there are limitations, particularly seeing below the jugular frame, and it's hard unless you're behind the sigmoid sinus. Excuse me. But of course, you have a very, very good view above with this transtentorial transpetris approaches. But anyway, today the focus is the retrosigmoid. Very basic, very standard approach, easy to use. Positioning. I'll talk about positioning a little bit, but the one point I'd like to make about positioning is I know the classic for MVDs and things is to turn the head towards the floor. But nowadays with modern operating tables, if you can rotate, I actually like it quite flat. We don't use retractors, as you'll see, and I like a view forward into the meatus and also backwards into towards the brainstem. So for me, I like a sort of flat approach to it. And I think it's very important to understand what you can change during the operation and what you cannot. So let's talk about positioning. This rotation towards the floor is less important nowadays with modern operating tables. What you must do, of course, is to laterally flex. That's really important. And that sort of brings the slope of the posterior fossa towards you. And the thing of course, you cannot change during the operation is opening that space between the ear and the shoulder. So really opening up that space and bring the shoulder down is important. So these two things you cannot change during the operation. Rotation, not so important. You can definitely change during the operation. So whenever you're positioning a patient, it's really important to understand what you can change, what you can't. And this is our view in the retrosig. Whatever incision you like, it doesn't really matter. We sort of favor a lazy S. We do the same if we're doing a far lateral. We don't really favor hockey stick incision, so we're big fans of this sort of lazy S incision. Small, big, whatever you like. I'm not fussed on that. Of course, when you're starting out, you have to remember the landmarks of the asterion and how it relates to the transverse sigmoid junction. But super important that you always expose a little bit of the sigmoid, a little bit of the transverse. And as most of you will know from doing lots of these, that when you make the cuts, some bits are harder, particularly this corner. And you really want to drill that corner. It gives you a nice view to the jugular frame. And so if you can't get to cisterna magna, or once you've drained cisterna magna, you can also drain CSF here in the medullary cisters. And we find it helpful, particularly when people are starting out, that you take this bit of bone here as well. It just allows you easy access to cisterna magna, which of course is the first step in the retrosig. Now, if you're a skull-based surgeon, of course, you definitely understand the sort of basic retrosigmoid craniotomy, but then you must understand all of these. All of these extensions are really important. And today I'll talk about the transmeatal, because that's probably the easiest and most commonly used. So that's probably the first one to start with, is transmeatal drilling. I'll show some examples of that. Then you can build up to sort of reverse Kawases, which are very, very nice. Supracerebellar approaches, cutting the tentorium. Inframeatal suprajugular, you must understand, but much less common. And it's not uncommon for us to cut the tentorium in a lot of these, particularly for some certain petroclivals, if we use a retrosig, or even add a retrolabyrinthine. This is one of our intraoperative pictures where the patient had good hearing, where we've done a retrolab approach to give that additional view in front of the sinus for a meningioma. And of course, you can combine it with, it's part of the combined petrosal, it's part of a far lateral. So as a skull-based surgeon, you should be able to do all of these things. And I'll show the sort of easier examples of that. I think everybody understands the anatomy of the transmeatal, but you have to understand that your limits of the drilling to the vestibule and study your preoperative scans very, very carefully and understand the anatomy of the labyrinth in relation to your drilling, particularly if you're considering a hearing preservation operation, as we often would for some vestibular schwannomas. The next big thing to understand, just because I'm going to show it in the video, so nicely described by Michiro Kuno. Lots of people have shown this, including in this Chinese paper, which had a nice diagram, is this sort of perineural plane around vestibular schwannomas, the so-called sub-8 plane dissection, which is very helpful because when you're in the sub-8 plane, you cannot injure the seventh nerve, and it helps you get a complete resection. I'll show that in a video. Okay, yeah, this is obviously for people who don't do this very often. Like I said, really important. Craniotomy is tight and onto the sinuses. You cannot fear the sinuses as a skull-based surgeon. Drain cisterna magna, open up, get access assistance. You never need a retractor in the CP angle, really. And you should understand the extensions. I'll show the easy one, which is transmeatal. So here's a case, classic case, vestibular schwannoma, 32 millimeters, usual CP angle symptoms. And given the mass effect on the brainstem, she's relatively young, opted for surgery. I'll just show you contrast scan first. So not, not hugely large tumor by any means, extending nicely into the porous. So we want to get all of that tumor out. The goal is always a complete or near complete resection where possible. And I'll just skip forward here. Sorry, that bit's not playing. Anyway, you saw it on the contrast scan. Okay, so we're on the left-hand side. This is the start. So this tumor, slightly cystic. Usually we like our sort of forceps and peeling, but here it was just a little bit more stuck. So left-hand side, tentorium's there, low cranial nerves. Usually don't need sharp dissection. It's all, nice arachnoidal peeling, but this tumor was just a little bit more stuck. Like always, when you go in, you never bipolar the tumor. There's no need. You have to start to peel the arachnoid layers away. You're going to debulk. I'm going to skip forward here. Once you've cleared the tumor away, you're going to start to debulk. And this one is just a little bit more stuck, so I'm having to sharp dissect, but normally it's all done just with peeling. Also a little bit vascular, so I had to bipolar a little bit. Again, we don't like that. As the previous speakers have said, you really want to minimize the use of bipolar around cranial nerves, so we don't favor it. Sadly, we don't get to do the sitting position, and you could even minimize even further. Our anesthetists are not keen. So low cranial nerves have come off very nicely. You saw this sort of ica there. Tumors being debulked. In the interest of time, I'm going to skip forward here and just show you that once we've cleared it off the brainstem, picked up 7 of the brainstem, we're then going to drill and open the porous, this transmeatal extension. So yeah, all sort of very standard arachnoidal dissections in the CP angle. We're going to pick up 7 there in its usual place at the brainstem. And once we've debulked a lot of this tumor, then we'll open up the porous. Never need a retractor in the CP angle. Never, never. Good. Now we've just the bit earlier there just showed you 7 on the lower end of the tumor. Tumor's coming off just a little bit more stuck than usual, so just a little bit more force than you would normally use, and just the vascular nature of it, so a little bit more coagulation than we would like, but sometimes you don't have a choice. But we definitely favor very, very minimal coagulation. Right, I'm going to skip forward here. Obviously, you don't expect the facial nerve there. It's going to be around here, going around the back, although it is variable, so you always check. Again, having to sharp dissect because it's just a bit more stuck. There we go. So tumor coming off the brainstem. 7 and 8 to the brainstem. We keep 8. We're going to go in this sub-8 plane along 8, so you cannot injure 7. So thinking that I'm going to go forward here. Just I'm keen to show you some of that drilling. We open the gutters. Yeah, tumor's bleeding a little more than you'd expect, but it's fine. Good. Okay, so that's that. Most of the tumor's been taken out. So inferior gutter, superior gutters, you want a nice sort of 270 drilling. Usually the plane again is very nice. You go as far enough so you're distal to the tumor. Obviously, you cut the vestibular nerves, but obviously not the cochlea, not the facial nerve. Facial, as you know, is there. Cochlea here. So nice view there. Facial, cochlea, vestibular nerves have been cut. Tumor rolling forward. And the aim always is a complete resection and an intact facial nerve. I think in the interest of time, I'm going to skip forward. Planes are very, very nice. Tumors coming away very nicely. Just debulking the last bit, so there's very little weight as I dissect the last bits off. So this very standard vestibular shunt. I'm sure you've all done hundreds of these. Again, a little bit more sharp than needed. Usually we want to preserve all this arachnoid. That's the trigeminal there. We'd usually like to preserve all of this arachnoid over the low cranial nerves, over the trigeminal, but here we're having to sharp dissect it off. That's fine, but not our preferred method. This one's just a little bit harder than usual, but still quite straightforward. Okay, nice view. Tumor coming off 8. So I'm sort of in that sub-8 plane. That's facial there. Very, very safe here. This obviously been sped up. And tumors just coming off 8, coming off 8. At 3.2 centimeters, this patient did not have good hearing, so we're unable to protect hearing. Good. So the tumor coming out of the porous. This is the last bits. I'll just show you the final view. Yeah. Okay. So complete excision, facial nerves completely fine, electrically fine, and obviously postoperatively fine as well. So this is the post-op scan. As you'd expect, all of the symptoms get better, and you've got a complete resection there. Well, with an intact nerve, as you'd expect in these cases. Okay, I'll just show a slightly different case now, probably even a little bit easier actually. So this is a petrous meningioma. Here the aim, of course, is to get again a complete resection, protect the hearing. Definitely in this case, that's the postoperative scan. I'll just show you the video. So same again. It's all about that peeling. We don't want a minimal bipolar use. So just getting the arachnoid layers off, and that's a really beautiful thing about CP angle surgery. Really, really nice layers. I think I'm running low on time, so I'll skip forward. So yeah, tumor's just coming away nicely. This is a really nice case, actually, very, very straightforward. A little bit vascular, but doesn't matter. Arachnoid is preserved. Again, we're on the left-hand side, so low cranial nerves are there. Tumor coming off nicely. In a minute, you'll see 8, yeah, then 7 is going to be deep. So in the interest of time, I'll just skip forward. A little bit of sharp dissection required. But coming away really, really nicely. As you'd expect, nice CP angle tumor, you don't fry the arachnoid to the tumor. All comes away nicely. So skip forward again. That's the inferior gutter. We're going to drill the superior gutters, just like you saw in the last video. Meningioma is actually probably even easier than in some schwannomas. These are obviously not petroclivals. That's much harder. This is a middle petrous. So that's now the dissection of the porus. We're going to get that plane. Tumor is going to come forward. Yeah, so that's all. That's what I've skipped forward. That's all that tumor out of the porus, trigeminal in the distance. And as you can see in this postoperative scan here, it's a complete resection. I'll show you the picture at the end. So that's the last bits coming out. Facial and vestibulocochlear below. Good. So just to say, retrosigmoid, very basic. Everybody can do it. You need to add on these sort of extensions to it. We would expect to have, very good facial nerve outcomes. Should get good hearing outcomes. Some more in meningiomas, vestibulocochlear can be harder. The whole thing is standard microsurgical technique, retractorless. You have to know these things as a skull-based surgeon, but you can do almost everything with the retrosigmoid. And I'd like to invite everybody to London. We're having 100 years of British neurosurgery, so we'd love to have you here. Please drop me a message. We'd love to have all of you come. It'd be amazing. Thank you again for organizing a fantastic conference as always, Sameh. So thanks for the invitation. I have a big team. I don't do this alone. Huge team of some of my ENT colleagues who do some of that drilling I've just shown you there, particularly in the pre-sigmoid approaches. So big team here in Oxford. Thanks again. Thank you very much.
Thank you, Dr. Sanjeeva, for an excellent talk. Now we are open for questions and comments. I think it was a long day, so
thank you.
Despite many things to be discussed, I think some other time we can explore further comments. Thank you so much again, Jiva. This will be the moment when we finish our day, and our last speaker is Professor Edgar Nathal. He's a very senior professor, and topic of presentation is a long track record of educational and clinical activities, and mentor to many. His topic of presentation is surgical experience with the extradural keyhole perional approach for paraclinidal aneurysms. A good and safe approach for complex lesions. Professor Nathal, please.
Okay, thank you very much for the invitation to this event. And we will talk about the meningeal extradural approach for paraclinidal aneurysms. I work at the main reference center for neurological disease in Mexico City, the Instituto Nacional de Neurología y Neurocirugía, and we are devoted only to the treatment of vascular pathologies. So in this way, we treat aneurysms, AVMs, cavernomas, bypass surgery, carotid endarterectomy, carotid tumors, and dural fistulas as well, and the new evolving technique for acute occlusion of the intracranial vessels like the surgical thrombectomy. These are our residents that has been there making the postgraduate course of vascular neurosurgery from all over the countries of America Latina, Latin America, and with all of them, we have made some progress in the treatment of the surgical of the cerebral aneurysms. This is the pteryginal approach, as Professor Yassagil described it, center over the sylvian fissure, but exposing a little bit more of the frontal lobe and the temporal lobe. The key point to use this approach, as was described, is the splitting or the opening of the sylvian fissure to reach the basal cisterns. This was not designed to make a retraction of the brain at the frontal lobe or temporal lobe with the risk of contusions or any lesion, including the premature rupture of the aneurysms while exposing only by retraction. I have to recognize the pioneer work of Professor Fukushima, Professor Pernesky. I was allowed to visit both of them in his places, so I learned very much about the concept of the keyhole surgery. Until now, there are many keyhole approaches, interhemispheric approach, frontal approaches, subtemporal approach, suboccipital approach, and the eye-brown approach for cerebral aneurysm. However, any of these approaches has the advantage of the view of the pteryginal approach. So with this in mind, we decided to include a new perspective on this approach. This is a drawing of Professor Kamiyama in the Sentaro Ito's book about cerebral aneurysms. But I decided to go further ahead with this small craniotomy centered over the pterion in order to reach the sphenoid ridge and then dissect the sylvian fissure down to the basal cisterns. This is the concept that I originally have in mind. So I take all the reference that we use in the standard pteryginal approach, like the pteryginal area and the sphenoid ridge. So we take this line that is the sylvian line, the projection of the sylvian fissure, and look how it it goes through the pteryginal point. So I decided to make this small craniotomy with only one borehole at the most caudal part of the craniotomy. And this triangle represents the area that should be drilled to get the final space that is shown in yellow color. I have to say that I don't need to detach the temporal muscle as we do in some approaches, but we go under the temporal muscle in direction of the sphenoid ridge. The paraclinoid aneurysms, as you know, there is a heterogeneous group of aneurysms with different directions according to the forces that produce the weakness of the arterial wall to produce an aneurysm lesion. There are many classifications. I use my classification that is very simple. Divides these aneurysms in dorsal and ventral aneurysms according to the main direction, because this is very important during clipping. At the beginning, you should have in mind very clear the way that you will approach the aneurysms. This is a region, because of the carotid siphon, that receives many forces, wall shear stress forces at the wall of the artery, and then many aneurysms can be produced at this zone. 25 years ago and more, the results of the most published series about paraclinoid aneurysms was very bad, actually. because if we analyze this paraclinoid area, all the area is covered by bone and dural folds. So we only see the intracranial part of the carotid artery, but all that is proximal, including the siphon, is very difficult to expose. So we have to learn how to take out this bone and dural structures. When you retire the anterior clinoid process, you can see now the internal carotid artery and the ophthalmic artery. But if you cut the distal dural ring and proximal dural ring, so you have all the siphon exposed even into the cavernous sinus. So this is a very good place to take a proximal clip in cases of small and middle-sized aneurysm. But this requires laboratory work and also technical skill to get this situation from this that was originally seen when you expose this region before dissection. So in a lateral view, after dissection of these dural covers, you see the siphon, the artery, the ophthalmic artery, the distal dural ring, and the proximal dural ring. Behind the proximal dural ring, that is actually a membrane wall, you can see, or you are into the cavernous sinus. The cavernous sinus then can be approached from the upper part, or if you desire, you can make a peeling of the middle fossa and get the vision from the lateral side. This is the endoscopic view that most of the surgeons of skull base make nowadays to expose this carotid from other view. The anterior view that expose also aneurysm in the region that actually there are reports of treating by endoscopic methods some paraclinoid aneurysms. So what we want to get at the final before clipping an aneurysm is the total exposure of the optic nerve, including its covers, as well as the carotid artery exposing the distal and proximal dural ring. The distal dural ring can be cut on the upper and under surface of the internal carotid artery to mobilize in case of complex aneurysms, especially the lateral directed aneurysms. So this is another problem that we have. I will not talk about it, but is the problem that has the endovascular therapy treatments in the paraclinoid aneurysm. Before, when they use only coils, the recanalization of the aneurysms was the rule. Now, after advancing with the stents and coils, and now with the flow diverters, many aneurysms has been treated successfully. However, the rate of recanalization is still higher than the rate obtained by neurosurgical methods. I present my initial steps in the mini-terminal approach, my version of the spheno-ridge approach, in Cairo in 2001 in one of the meetings of Professor Pernesky, and I present a small series with this concept that I was treating successfully these aneurysms. I mean, all the aneurysm of the anterior part of the circle of Willis, and mainly the MCA that are very easy to treat by this way. We published our original paper in 2005 in operative neurosurgery, and this is, I will explain quickly how is the basis of this approach. This is the McCarthy point, and this is the incision over the hairline behind the lateral part of the orbit. We can extend, if we want, to the temporal side of the frontal side, if necessary, according to the location of the aneurysm. And this is a comparative view of a 3D reconstruction between the standard terminal approach and the craniotomy made for our approach. This approach fulfills all the requirements that fills the terminal approach in terms of security for the patient. Obviously, we cannot put in risk the patient with such a dangerous lesion. So this approach was tested mainly to fill all the requirements, security requirements for the patient. I'm not in agreement with this concept of a keyhole approach. That means great exposure of tissue, bone, soft tissue, to make a small craniotomy and to make even a smaller dural opening. This is obviously not the concept that I think should be managed in the keyhole approach, because if I make such an exposure, maybe I should use all the exposure to get the aneurysm, and could be safer even for the patient than this small approach making with a great dissection. I present my results in the two versions of the Schmidek and Sweet with the standard approach. These papers, these chapters were written before the introduction of the keyhole and the extradural approach for paraclinic aneurysm. Now, most of the unruptured and good grade patients with small and middle-sized aneurysm, paraclinic aneurysm, we operate now under the concept of the extradural keyhole approach. These are the steps for this approach. Is the same that the standard pteronal approach, but it includes the extradural keyhole, the extradural cranioidectomy, the dural opening of the optic nerve, the linear opening of the proximal third of the sylvian fissure only to expose the basal cisterns, as I will show, in the dissection and clipping of the aneurysm. These results has been, and the technique has been published previously in Acta Neurochirurgica and another medical magazines, but the main characteristics is that we are still respecting all these steps to make the paraclinic aneurysm as we do in a standard craniotomy. I will show you this technique in video. This is an example. It's a patient with paraclinic aneurysm. I will go faster. Here is the MIPS image showing the aneurysm in a dorsal fashion. This is an upward directed aneurysm. And this is the position of the patient. And here is the planning. This is a line behind the lateral rim with exactly at the hairline. At the beginning, we make a small craniotomy, as I showed before. And the first step is the drilling of the sphinal ridge, and then to complete the extradural cranioidectomy. Okay, here we are exposing, I will go a little bit faster, exposing the cranioidectomy. This is get in one piece. And after then, we retract the dura at the top frontal and temporal lobe, and we open only the proximal third of the sylvian fissure to get the basal cisterns. Now we are seeing the optic nerve, the CSF is released, and we inject a little bit of a hemostatic sponge to avoid the bleeding from the cavernous sinus. Now you can see the internal carotid artery between the distal and proximal dural ring. Here is some bleeding coming from the cavernous sinus, but this is the place that we use for proximal controls if necessary. Obviously, in enough cases, we prepare the neck just in case, but never have been used the neck to proximal control, because at this point it's very easy to get it. Now we are separating the internal carotid artery from the optic nerve. You can see the ophthalmic artery. And now we cut the proximal, the distal dural ring, beginning at the lower part of the carotid, and then we move into the upper part. In this way, the internal carotid artery is completely free from any attachment, and we can mobilize as well as the aneurysm if necessary. Now you can see the distal dural ring, proximal dural ring, and the aneurysm. So we have the total control, proximal control, distal control, and the exposure of the dome. After complete exposure, we proceed to make a proximal clipping and to use a straight clip to close completely the upward directed aneurysm. We use a second clip to reinforce the first attachment of the clip, and now we cauterize the dome of the aneurysm and the surgery is finished. We confirm with fluorescein the patency of the internal carotid artery, and this is the postoperative views of the surgery. This is another case I will show you quickly because the basic concepts has been established. Then we proceed to the extradural clinoidectomy. We retract the frontal and temporal lobe to augment the exposure area. We open the proximal part of the sylvian fissure just to release the CSF from the basal cisterns to use all the space to identify the optic nerve, the internal carotid artery. This is a ventral type aneurysm, so you have enough space to complete. We punch the dome to verify that it's totally clipped, and we put a second clip to complete the total occlusion of the aneurysm. Look how small is the craniotomy, but inside you have the same space that you get in any other standard approach. This is another case, only to repeat the sequence. And this is other rupture case treated before, as I remember, by coils. This is the planning, the drilling of the sphenal ridge, the extradural cranioidectomy, the opening of the sylvian fissure, and the exposure of the upward directed aneurysm, so we can have the total exposure to get a safe clip. If necessary, obviously, it is exposed the carotid between the dural rings, just in case of a temporary clipping, if necessary, or in case of aneurysm with a very thin wall, to use at the beginning the temporary clip to avoid any intraoperative rupture. The closure is very easy. We put some amount of hemostatic sponge, and this is our final view of the craniotomy and the 3D reconstruction of the clipping. So some only as finally some demonstrative cases. This is a dorsal type aneurysm, distal dorsal type, distal because it's far from the ophthalmic artery, and this is the pre and post-operative and the patient after operation. This is another case. This is a middle-sized aneurysm. You can see some deposits of calcium at the wall, so it's a very hard aneurysm. We treat this case. This patient have a renal failure, so the endovascular therapists declined to treat this case because the need of using maybe a high amount of contrast medium. So we decided to do with this approach, and this is the final view, the patient mobilizing the left side when the aneurysm was on the right side, showing us that in this case there was no any lesion for the patient. So the final message is in the fighting between the endovascular therapy and microsurgery for aneurysms. I think that the most important point is the local team, because if you have a very good endovascular therapist, maybe this is the best way to treat the cerebral aneurysms, including in this location. But if the surgical team is has enough experience, maybe this is the best way to treat them. So at the final, I say the God's equations for every patient is to be at the right place, in the right moments, with the right people. And with this, I want to say thanks for your attention. And if you want to see more of these small approaches, keyhole approaches, I have a channel in the YouTube that you can access freely, and you can see all these kind of surgeries, only vascular procedures. Thank you very much for your attention.
Thank you, Professor Natal, for very insightful. Any comment or question for Professor Natal? Professor Natal, can we utilize the same approach for distal ICA, PCOM, anterior choroidal?
Excuse me.
You're mute. You're mute.
You mean the extradural approach?
Oh, yes.
No, we use the same approach, but the opening for most anterior complex aneurysm, I mean anterior circulation aneurysms, the dura opening is different. We open in a semilunar fashion, and we split the sylvian fissure completely. Only in the paraclinoid aneurysms, we use this variation of the extradural approach. But the remaining, we use the standard opening in a semilunar fashion, as I said.
Thank you.
I just I want to congratulate Professor Natal of, as always, a brilliant presentation. I want to stress that it's very important that his philosophy in this paraclinoid aneurysm is because he used the extradural corridor. The removal of the anterior clinoid extradural and all the room that he made make it possible that he have a very good room to clip this kind of aneurysms. You know, it's very important that because most of the neurosurgeons believe that only the subdural clinoidectomy is easy or is safe. But you need to think about the subdural clinoidectomy. You need to split the sylvian fissure. You need to expose everything in order to your drill have room to work. But in this approach, you don't need that because you use extradural corridor. Even you can have proximal control in the clinoidal segment or in the cavernous portion without move anything in the brain, without open any cistern. I'm not saying that you don't need to open the cistern. I'm saying the philosophy, the minimal invasive philosophy is you need to do what the patient need in order to make a safe surgery, not what you need because you are unsafe surgeon. It's very important that this is a very long way. It's a very long way. But if you think, for example, when Walter Dandy operate, and Jasahir came with the craniotomy. Maybe a lot of neurosurgeons said that Jasahir was crazy, too small craniotomy, the light is not going inside, you cannot see the structures. And now we are discussing about the Natal approach against the Jasahir approach, for example. And then it's the same. They say, no, this is too small, you cannot see the structure, it's always the same. And maybe in the future, the people don't even open the head and they can do with a robot or something in opening of 1 millimeter. You know what I mean? And then it's very important because the technology, we need to use it. the augmentation of the microscope, the augmentation of the exoscope, the endoscopy, everything. And that's why we can do surgeries that maybe 20 years ago were crazy. But today, this is a reality. And we need to offer this kind of surgery because our competition is the endovascular. And then we need to offer very good results with very minimal invasive surgery. That's why I follow the philosophy of Professor Natal. Thank you.
Yeah, thank you very much, Dr. Mura. I want to add that obviously the keyhole surgery is not for every neurosurgeon because I think that is very important, your school. If in your training people uses the keyhole approaches, you will be very familiar with them. But if you are trained in a standard and all approaches, you will feel a very narrow corridor, but actually when you dominate all these issues, the space inside is exactly the same. There is no difference between a very big approach and the keyhole approach when is very well directed. So I invite all the young generations to visit all places in which the keyhole approaches are made, including ours. You are invited anytime you want to come to see these approaches and to convince if it is appropriate for you or not. In the while, I invite you again to see videos because it's another way that we can imagine how these approaches are done. Thank you very much.
Thank you so much, Professor Natal.
Thank you. Thank you. Now we will reach to the end of the day, first day of fifth World Skull-Base Annual Congress. I congratulate all of you for this marathon, which has been for about 14 hours, 14 continuous hours. And I take the chance to thank my dear friend, Professor Hata, for his acceptance of co-sharing all this day. He didn't miss even a minute. Great effort from him for today, and we are waiting him for tomorrow also. Thank you.
Sure.
Thank you all, and thank you every speaker who have spent a lot of time to gather all this data and update all our knowledge about Skull-Base. And see you tomorrow the same time, 9 a.m. KU local time. Thank you.
Thank you.
See you tomorrow.
Bye.
Bye bye.
Right.